Good morning,
Morning.
everyone. I want to thank you all for joining us for the 2022 Virtual Science Annual Scientific Meeting, Bloodless Medicine Education, the Ultimate Game Changer. This is the last day of the three-day program, and we want to thank all our speakers and participants for making this such a wonderful and informative meeting. I'll be moderating today's session with a co-moderator, Dr. Mather. He's a medical director of transfusion medicine, Department of Pathology and Laboratory Medicine at Children's Hospital of Los Angeles, associate professor of clinical pathology at Keck School of Medicine, University of Southern California, and the chair of the SABM membership committee. I'd like to welcome Dr. Mather.
Thank you so much, Cassandra. Good morning, everyone. I'm so excited to be here co-moderating this session, the SABM session of the Bloodless Medicine and Surgery annual meeting here. We have a great lineup of speakers today. The theme of this session today is that this whole meeting has been education, and we have three pathologists who are giving this session today. So who better to educate than the physician pathologists, like we have been working on the field of PBM, patient blood management, educating other physicians, working with other physicians to make patient blood management a standard of care everywhere. And BMMS has been working with SABM, the Society for Advancement of Patient Blood Management, as our organizational affiliate to make PBM a standard of care all over the world. So we'll start today with the first speaker, Dr. Refai. Dr. Refai is the professor of pathology and laboratory medicine at the University of Rochester Medical Center in Rochester, New York. He is the director of thrombosis and hemostasis lab. He is also associate director of blood bank and transfusion medicine, as well as associate director of therapeutic apheresis. So along with his all clinical administrative duty, he is a prolific researcher. His research focus are on the in vitro and in vivo effects of ABO antibodies and ABO immune complexes on platelet function, coagulation, and endothelial cell integrity. He has published more than 130 reviewed articles and book chapters. And today he's going to talk about why does blood transfusion results in tissue hypoxia. So I'd like to welcome Dr. Refai.
Thank you very much for the nice introduction, and thanks for having me, and thanks for the BMSS to organize this nice meeting. I'm going to share my slide here in a second. Okay, one more time.
Okay, that's good.
Can you see my full screen or?
Yes.
Okay.
Yes.
Okay, great. So, the entire idea of this presentation is: are we doing any good for the patient when we transfuse them red blood cell? The objective of my calls is to describe the oxygen hemoglobin dissociation curve, talking a little bit about the storage lesion of the red blood cells, and understand that red blood cells transfusion effect on tissue oxygenation. So for the last couple of days, you heard a lot of talks about anemia, and you know it's the most common disorder worldwide, actually, from west to east to south to north. You can see between 3% of the population to almost 40% of the population, depending on which data you're looking at. But this is data from 2018, and you can see how prevalence is anemia worldwide. Luckily, hopefully it's luckily, I'm not sure about this, but the iron deficiency anemia is the most common anemia worldwide. Even in the ICU patients, the frequency of anemia is almost 8%. It's been published recently. Blood transfusion usually used in these patients, unfortunately, especially if it's in elective situations sometimes, they use the transfusion to support the anemia and instead of fixing the anemia before the patients got admitted, which in their criteria, they are supporting the hemoglobin. I'm sorry, they're increasing the hemoglobin to support the oxygenation. Although the red blood cell could be a life-saving, as we know, in massive bleeding or in traumas or in patients dependent on transfusion, but it doesn't come with no risks. So risks could vary in severities and could include a lot of complications, as you can see here on the screen, from hemolytic reactions to allergic to non-hemolytic reactions, febrile non-hemolytic, circulatory overload, trolley infection, and ongoing. So when we store red blood cells in the blood bank, there's a lot of things going on the blood bank, on the stored red blood cells. Could be metabolic, biochemical, or even molecular changes of the red blood cells, and even change in the shape of the red blood cells. And the significant ones include also the drop in the ATP and the 2,3-DPG. These are the most significant ones that affect the oxygen delivery. This is just like a most recent data, kind of like a collection in one review of the entire changes happening during the storage, the consequences on the red blood cells, and even after the transfusion in the patient. And I'm not going to go through this. Definitely, it will take me more than an hour this morning. But I'll leave this just for your entertainment, just to go through it. I really like it because it's really linked each changes to the outcome of the transfusion. If we go back at beginning of the 2002, actually, a study was published showing the changes, the electronic microscopy changes of the red blood cells during storage. And as you can see at the beginning, which is around the first week, you can see the dominant discocytes red blood cells. I mean, this is a very normal red blood cells. Moving forward, couple of weeks, it starts to get less and less, and more of the echonocytes. Echonocytes has a couple of issues here. First, it does not move very well in the capillary system of the body, of the circulation, and also does not release oxygen easily. So this is just for the changes of the membrane of the red blood cells. By the expiration, by 42 days, you rarely can see any of the discocytes red blood cells, any normal red blood cells you're comparing to the first week. This is just to show us what exactly happening. We know that a lot of things happen during the storage, but I was not anticipated to see this within the first few hours. Like, look at the pH, how it dropped, and look at how significantly the 2,3-DPG drop was in the first few hours. And by the 24 hours, it's almost about, I would say, 30 to 40% less where we started. By 2 weeks, you basically almost close to undetectable. And this is very important in binding and releasing the oxygen to the tissues. Oxygen saturation, that means that the more oxygen will stay in the red blood cells, and that's increased significantly over the storage. This is another study, was to show us and to compare between whole blood versus suspended red blood cells. And they studied the 2,3-DPG, and as you can see, it decreased significantly within the first week. This is another study to show us how significantly it does decrease. By almost the fourth week, third to fourth week, it's like very, very low and almost non-detectable. And the oxygen release, which depends 100% on the 2,3-DPG, as you can see here, also dropped accordingly with the same time of the dropping of the 2,3-DPG in this study. This is not new. This is not fresh or not just recent. Since 1969, and even I found studies from 1954, to be honest with you, but I wasn't able to get the article or even to get a shot of the first page. They were studying and they were anticipating that there is some changes on the red blood cells when we store it, and these changes affect the patients after transfusion. And what they found in this study, they studied the 2,3-DPG in the red blood, in the stored red blood cells, and they saw that it strongly depends on the pH of the red blood cells. And then they investigated the level of the 2,3-DPG and ATP in stored red blood cells, incubated in fresh plasma. So they took red blood cells, stored red blood cells, and incubated in stored plasma in fresh plasma at 37 degrees with a normal pH to stimulate the condition after what happened with transfusion. And they saw that the ATP level remained relatively stable under these circumstances, and the 2,3-DPG started to gradually increase. But almost after 8 hours, only 1/3 of this 2,3-DPG was repleted. So it was increased in the red blood cell incubated with a fresh plasma. So their conclusion was stored red blood cells may fail. I mean, they did not have a lot of technology at that time to help them drive this conclusion, but they said it may fail the oxygen, transporting oxygen efficiently to the surrounding tissue, even to the tissues, even after several hours of transfusion. The measurements of O2 delivery and consumptions taken before and after red blood cells revealed decrease in P50, and this P50 is like the 50% capacity of the hemoglobin to carry oxygen. And that's likely to increase the affinity to the hemoglobin. So when you, as you're going to see in the next few slides, when you look at this oxygen dissociation curve, you'll see there's a little bit change of the V50 will allow the hemoglobin to capture or to increase affinity to the oxygen. And that's reduce the transportation of the oxygen to the tissue. Another study was done in 2011 by Dr. Sadak et al. They studied these changes of the microcirculation in sepsis patients after 1 or 2 red blood cell transfusion for a hemoglobin between 7 to 9. They measured the oxygen saturation in thinner tissue, and to be honest with you, although I'm a pathologist, I don't know where are these thinner tissues, is the 3 muscles at the base of your thumb. So they used a tissue spectrometer, and also a vaso-occlusive test was performed before and 1 hour after transfusion. And they saw no significant changes in the muscle tissues after 1 hour of finishing transfusion. This is what they found. They definitely, and this was, as I said, what's 2011. It's definitely, they saw an increase, significant increase in hemoglobin. They did not see any changes in any of the oxygen parameter that they measured in these patients. And even with the this is called the flow of the oxygen. So this is the inspired oxygen versus the saturation of the oxygen in the circulation, and they did not find any changes during the 1 hour after transfusion. Weinberg et al. Also studied the muscle tissue saturation in trauma patients after transfusion of all the red blood cells to explore the effect of the storage lesion. And saturation was measured continuously by near-infrared spectroscopy during the course of the transfusion of only 1 unit. Pre and post perfused capillary vascular density was also determined, and they found that a decrease in muscle tissue oxygenation and the perfused capillary vascular density, which was associated with the transfusion of older red blood cells. So the older red blood cells, the less oxygenation also would happen. And this is the graph they show us, that they start decreasing in the oxygen saturation even after 1 week. But when you get to the final, the 35 or 42 days, basically it was significant difference in the oxygenation. This is the normal oxygen dissociation curve. As you can see, there's a lot of, this is how the oxygen gets bind and released to the tissues by the red blood cells, the normal one. And the stored red blood cells usually get affected to the left shift. And that's due to the increase, the decrease in pH, decrease in 2,3-DPG, and the P50. So a little bit of change in the P50, as you see, it will cause this shift to the right or to the left. So that will bring me to our study. So we did a study, it was published last year, and we wanted to study the effect of the red blood cell transfusion on the peripheral capillary oxygen and the PaO2, which is the partial pressure of the arterial oxygenation. The aim, as I mentioned earlier, was to evaluate changes in oxygen standard parameters in adult patients before and after red blood cell transfusion. It's not easy to be done in adult patients, and it's not easy to be done in patients who are basically measured their oxygenation or assess their oxygenation. So we have, besides that, despite improvement in hemoglobin levels after a blood cell transfusion, the high affinity for the transfused hemoglobin or for the transfused blood cells hemoglobin will decrease due to the almost non-detectable 2,3-DPG, and that will result in a decreased PaO2 and SpO2, which will affect the tissue oxygenation. So to evaluate the oxygen delivery, we use the two parameters, the SpO2 and the PaO2. SpO2 is a peripheral capillary. Usually you see it in the ICU patients when they did the detector on their tips of their fingers, and also the pressure of the dissolved O2, which done by the arterial gas analysis. And the SpO2 measure indirectly the hemoglobin saturation of these tissues, and PaO2 reflect the O2 uptake by the blood. So selection criteria was a little bit of a challenge here. So it's as you know, it's a single center retrospective observation study. So we included patients of 18 and more, hemodynamically stable medical ICU patients, routinely monitored by either SpO2 or both of them, or PaO2. Received only one red blood cells over a period of 36 hours, which will be about 12 hours before transfusion and 24 hours after transfusion. So we consider the transfusion as a time zero. Indication for red blood cell transfusion was specifically for hemoglobin level correction. That's what we received in the order, in the blood bank when they ordered the unit. And the transfusion definitely met our guidelines, which is hemoglobin of less than 7. Oxygen therapy and also mechanical ventilation were included in these patients. We excluded any active bleeding. We excluded patients undergoing medical procedures, transfusion of more than red blood cells, and also transfusion of any other blood products. And also if the patient's transferred to a different unit or outpatient of the ICU. So imagine this in an ICU patient. It took us a while to just get what our number, which wasn't that's a significant number, as we're going to see later on. So patients were identified through our blood bank medical records. So that's how my residents and my fellow started to track these patients from the blood bank records when they ordered these units. And then we collected the data and analyzed it. So patients who met the inclusion criteria, we between May 2018 to February 2019, about 10 months, we assessed the hemoglobin, SpO2, and PaO2. We also assessed the oxygen support, the amount of oxygen flow and concentrations during that period, during the 36 hours. The start of transfusion, as I said, was considered time zero, and data were collected and analyzed at 4 hours intervals, 12 hours before, 24 hours after. Storage days of the red blood cells. Also, we looked at this just to see if that will change any of these parameters. And then any relevant data from the medical record, as you can see here. So out of 267 patients that were kind of eligible for these criteria, for this study, only 106 patients were included because of the full data. And we separated them into two groups, the SpO2 and the PaO2. The mean age, as you can see, was in the 50s. 58% males. The primary diagnosis was 44% cardiac disorders, hematological diseases about 17%, and pulmonary disorders about 10%. Therapy was required. Oxygen therapy was required in almost 3/4 of these patients. 68% were intubated on mechanical ventilation and required oxygen level of about 47 ± 10. 28% were on a nasal cannula with about 5 liters per minute of oxygen. 4% required another form of delivery of the oxygen. This is when we compare the SpO2 between the beginning and over here I just choose 4 hours just to make it small, make the curve a little bit better, but there were no major changes here before the 4 hours. So this is when we transfuse the red blood cells. And as you can see here for the SpO2, this is our patients, 78 patients. The minute we transfuse red blood cells, by almost finishing the red blood cells, which could take between 2 to 3 hours, 4 hours sometimes, you can see the significant increase in the hemoglobin, which everybody knows this, but we improving oxygen. But you can see a significant drop here in the SpO2. Now, I'm not saying significant clinically. Difference between 96 and 98 or 97.5 is not that great clinically. Patients usually the range of normal is between 92 to 100 or 99. It's not a big deal, but it did not meet the idea of the transfusion. I mean, we are transfusing to improve oxygenation, okay? And when we see this, it's really something really strange. What happened here? And that's continued even after 24 hours. I mean, we were at the previous studies, and even for the people who reviewed our paper and commented on it, they said, yeah, we know, but after a few hours, the 2,3-DPG does improve. We saw from that study, like almost even after 8 hours, only 1/3 of the 2,3-DPG was detected to come back to normal. So basically, within even 24 hours, we're still not improving oxygenation. And this is not only in this in the SpO2, but also in the BO2, as we're going to see later on. So hemoglobin increased significantly. Average increase was up to 1.2 gram per minute for almost 24 hours. SpO2 within 4 hours did not change, and also through the 24 hours did not change. BO2, again, as you can see here, not much different before the 4 hours. This is the time of the transfusion and how they shifted here. Now, let me just explain a little bit about the BO2. I'm not sure if everybody is familiar with it or not, but just to remind you that BO2 is basically the oxygen concentrations in your arterial blood. So when it's going down, that's mean the oxygen is maintained inside the red blood cells. It's not released. It's not soluble. So that's what happened. You need more soluble oxygen. We need to see this going up here, because when the patient is taking oxygen through a ventilator or through a cannula or whatever, the oxygen in his blood should increase. That means it's more soluble oxygen in their arterial blood. Unfortunately, we are seeing the opposite here. Okay, and that's after the transfusion. If we left the patients with no transfusion, he may stay at this level. He may actually doing better than the transfusion. So it was significant over 24 hours. So the oxygen requirements were variable among patients throughout the study, but almost 20% of the ventilated patients required increased oxygen after transfusion. And we did see this in their charts. So this is a significant number. 20% of the transfused patients required more oxygen. 40% of the cannula oxygenation required also an increase over the 24 hours after transfusion. So indication of potential lower tissue oxygenation and lower soluble oxygen following a single red blood cells. We only included one red blood cells, remember. So during the study, no acute deterioration was observed in any patients, and if so, we eliminated that data. We did not include that patient just because we want to have as much as possible clean data. Red blood cells were either incubated in CBD or additive, and was like 35 or 42 days. But however, the average transfusion was similar to the national average, actually, which in about 17 plus minus 2 days. No association was observed between the age of the red blood cells and the oxygen parameters. And this is, again, only because it's not significant numbers. I mean, according to our statisticians, we need at least 500 to 600 patients in order for us to check on the red blood cells age. And we did not have this in our patients. The primary aim of the red blood cells transfusion in hemodynamically stable anemia patients is generally improve the hemoglobin level and enhance the tissue oxygenation. As we know, this is a general reason for transfusion. I want to improve my patient's hemoglobin and his oxygenation. Clinically, it's assumed that the decreased 2,3 dBg in the red blood cell is transient and usually replace their 2,3 dBg. Red blood cells replace their 2,3 dBg deficit shortly after transfusion, or however, multiple studies show us the opposite. The significant decrease in BaO2 in our study is an indication of binding of soluble O2 to the hemoglobin to the transfused red blood cells due to the increase in affinity for oxygen. And the decreased SpO2 demonstrate the reduced capacity for O2 delivery to the peripheral tissues. These changes were observed in hemodynamically stable patients over 24 hours and after transfusion of one red blood cells. And the question I want to ask here, what would happen if some patients receive more than one red blood cells? What would happen if some patients receive having some bleeding at the same time? Bleeding, that's mean he's losing his good red blood cells with good hemoglobin. And what happened in patients, in pediatric patients? There's some limitations. There are some limitations for this study. It's a retrospective data collection, only one red blood cells, including hemodynamically stable patients, to minimize, as I said, the possible interacting conditions and to better understand the oxygen transportation with this red blood cells. Currently, we are in the process of conducting a similar but prospective study on cardiac surgery patients population. And with this, I'll stop my presentation here. And I'm open also, by the way, for we are working with the IRB right now to start this study with pediatrics. I'm just going to take a couple of seconds to say that if anybody interested, I would love to do this as a multi-center study. So just let me know, and we can definitely work together to establish this. Thank you very much.
Thank you very much for that presentation. So we're going to introduce our next speaker. The topic will be the spectra of immunomodulation, a case for transfusion avoidance. And this part will be done by Dr. Neil Bloomberg, Professor of Pathology and Laboratory Medicine, Director of Transfusion Medicine Unit, Blood Bank and Stem Cell Storage Facility, University of Rochester Medical Center, Rochester, New York.
Thank you. Can you hear me? And questions, can you see my slides?
Yes, but not in the presenter mode.
Okay. See if we can get it into presenter mode here. Okay.
Yep. Yes.
Okay. For some reason, okay, let's get to the beginning. Thank you for the invitation, and I'm going to address a slightly different question. Dr. Afai just elegantly spoke to the issue of transfusion, red cell transfusion efficacy, and there's not very good news there, that except for life-saving volume deficits such as exsanguinating hemorrhage and patients who can't make red cells on their own, either because of disease or iatrogenic treatment, treatments that impair marrow function, it doesn't look like we're doing a whole lot of good. And so the story I'm going to tell you begins really in the 1960s and 70s, and I'll show you a tiny bit of data from then. I was invited to talk about immunomodulation, and I should say that this is a very controversial topic for a variety of reasons, and if there's time at the end, I'll address some of those questions. But I'd like to explain that what I'm talking about here is transfusion safety. In other words, the risks associated with transfusion, and some of them have been known for the better part of more than a century, such as hemolytic transfusion reactions. But the risks that I'm going to talk about have mostly been identified in the last 40 years or so. In fact, November 1982 is when a letter appeared in the Lancet from the late Louis Burrows and Paul Tarter at Mount Sinai, suggesting that patients with colorectal cancer who were transfused had worse clinical outcomes. And ultimately, the 1980s saw the beginning of finally looking at transfusion clinical outcome studies, which started to peak in the late 1990s with a study from the Canadian ICUs and Paul Hebert and his colleagues on transfusion thresholds. And this has really changed the practice of medicine throughout the world in many ways. see. So this is data from a long time ago, the late Paul Terasaki's UCLA kidney transplant registry. And for many years, it had been thought that when we transplant kidneys, transfusion was very dangerous because it caused sensitization and kidney rejection. And what Terasaki and others working in this field found was that, in fact, transfusion seemed to have a protective effect, in that if you had more transfusions, you were less likely to have your graft rejected. Obviously, the numbers today are up here, and so this is no longer an important clinical finding. And this was very controversial at the time, but it suggested that transfusions could immunomodulate patients, and they were thought to be immunosuppressive because the analogy was to the immunosuppressives at the time, such as azathioprine. And the other thing that Terasaki found was that the type of transfusions that occurred, ranging from the least purified whole blood to the most purified, such as washed or frozen cells, these are the days before leukoreduction by filtration, that in fact the least pure product, whole blood, which was transfused, strangely enough, by our standards, to patients with renal failure, actually had the most powerful immunomodulatory effect, whereas the most purified red cells had a dramatically less of an effect. And so this has been known now for about a part of 40 or 50 years. And what Tarter and Burroughs, the surgeons at Mount Sinai, found was that if they looked at a cohort of patients, and this is not a randomized trial, that in fact, the patients who were transfused had many more frequent and earlier recurrences. And of course, this was very counterintuitive at the time because very little was known about the effect of transfusion on cellular immunity, and almost nothing was known about the effect of cellular immunity on cancer recurrence. We now know that immunotherapies are in fact the most powerful therapies we have for treatment of some cancers. Various types of immunotherapies, including CAR T cells, are now showing dramatic ability to cure diseases, even at the end stage of diseases like leukemia and non-Hodgkin's lymphoma. But none of this was known at the time. So this was really quite counterintuitive. And we don't have a definitive answer yet, but I'll show you some additional data later. So Tarter went on, he was a resident at the time, to study infection. He reasoned that if transfusions were immunosuppressive for the and that was good for kidney transplant and bad for cancer, that it might be bad for surgical infections. And he published some data. And this is a study from Lillian Burroughs at Louisville. She was a trauma surgeon there. And what she showed was that there was one of the most dramatic associations between a therapy or a treatment or a habit such as smoking. Smoking in lung cancer is about a 20-fold increase. Smoking in heart disease, about a 10-fold increase. And what you can see is there's a dose-response effect between the number of units transfused to trauma patients and the incidence of patients with infectious complications. Now, obviously, this is not a randomized trial. It could be confounding, but when you have an almost 10-fold increase in something, it's very unlikely to be confounding. And in fact, in animal models, it was shown that transfusions do, in fact, impair host defenses, as Tarter hypothesized, against postoperative infections. And this is a more recent example of a cohort study in the Annals of Thoracic Surgery, just showing an almost 10-fold increase in pneumonia in patients undergoing heart surgery. So what do we make of this? Well, you could argue that this is just an epidemiologic association, but in fact, we now have a lot of randomized trials, better part of 10 to 15, using leukoreduction, which removes most of the white cells and most of the platelets from transfused red cells. And this is just some of the studies. And this is a meta-analysis that just shows that if you look at leukoreduction, the studies clearly show a decrease. There's a lot of variation for various reasons, but that leukoreduction reduces postoperative infections by 30 to 40%. It doesn't make them vanishingly rare, but there is some benefit, and that's why universal leukoreduction should be used. There have been a fair number of randomized trials, including those in cardiac surgery, and those in cardiac surgery have shown a halving. These were done in the Netherlands, in Amsterdam, and in Leiden, and leukoreduction reduced the mortality rate in cardiac surgery, presumably from multi-organ failure, mostly because that's what the cause of death often is postoperatively, especially in patients with infections. And so literally a doubling of risk when you give non-leukoreduced transfusions. So most cardiac surgeons and cardiac anesthesiologists will absolutely insist that their transfusion service give leukoreduced blood. And as a side note, while there are 3 separate advisory committees that have asked the FDA to implement universal leukoreduction, the FDA in the United States has taken no action. The AABB has not recommended leukoreduced transfusions, even in cardiac surgery. And so this has become a political football, even though universal leukoreduction was introduced in Canada, the United Kingdom, and France almost a quarter of a century ago. And this is a rather sad story historically. So leukoreduction shows that the association between transfusion of allogeneic blood and postoperative infection and mortality is causal. It's not an association. Transfusion is causing these infections, causing these deaths. And in fact, there are data, which I'll show you a little bit, that autologous transfusion protects against these. These effects are not seen with autologous transfusion of various sorts, whether it be salvage, pre-deposit, autologous transfusion, or normal volemic hemodilution. So we know this is an immunologic effect. It's prevented by leukoreduction to some extent, and actually prevented almost probably to a larger extent by use of autologous transfusion. And in a meta-analysis that was done some years later, I'll show you restrictive transfusion strategies seem to have similar benefits to leukoreduction or autologous transfusion. So immunomodulation is real, and it can be modified but not completely obliterated, so to speak, by leukoreduction, and it can be dramatically altered by autologous transfusion or avoiding transfusion. One of the interesting things about leukoreduction is it's also, at least in our hands, reduced the incidence of acute lung injury to almost 0 in our institution. It's also dramatically affected the amount of the number of patients who were diagnosed with congestive heart failure, or as blood bankers like to call it, circulatory overload. I don't know why we needed to come up with a new name for something that was well established, but that's also reduced. And so we have a lot of benefits of leukoreduction if a patient is willing to accept transfusion and we use appropriate criteria. There are many, many advantages to leukoreduction to make transfusions safer. So these are the autologous transfusion data. These are some randomized studies. Marcus Heiss from what was then West Germany in the 1980s. And then after Germany was unified and he published the full data set, showed that autologous transfusion in a variety of settings, Heiss's was in colorectal cancer surgery, improved clinical outcomes in terms of cancer recurrence, but also had a striking benefit in terms of nosocomial infection, postoperative infection, reducing it by almost half. So autologous transfusion, and these are not all pre-deposit autologous. I believe Newman was a hemodilution, normal volemic hemodilution, and one of these studies was salvage. So there are a variety of autologous techniques, some of which are acceptable to all patients, can be used to reduce the bad outcomes after surgical interventions. And this is restrictive transfusion in the upper GI bleeding, a study from Barcelona, Villanueva and colleagues, just showing that the restrictive transfusion strategy, even in upper GI bleeding, saved lives. The overall survival in this randomized trial was twice. It was twice what the overall death rate was twice in the liberal strategy versus the restrictive strategy. And in fact, you can see why some of the, contrary to the arguments that transfusion is needed to prevent heart attacks, myocardial infarction, there were actually no heart attacks in the restrictive group, but 8 in the liberal group. So as Dr. Rafai was showing you, it may be that impairing oxygen delivery and increasing thrombosis, which is another effect of allogeneic transfusion, increased thrombosis, it actually makes things worse in terms of cardiovascular outcomes. And finally, this is restrictive transfusions. This is a meta-analysis, part of a meta-analysis that appeared in JAMA and is in a textbook chapter that I'd be happy to send to anybody who sends me an email. We've written a chapter on transfusion immunomodulation for a textbook. It's probably the only textbook chapter that treats immunomodulation in the broadest sense, and I'm happy to provide the latest edition of that. And as you can see, restrictive transfusion also reduces postoperative infection, in this case in orthopedic patients. So the question of what the effect of transfusion is on cancer when it is established is still an open question, but I think we know that it clearly has effects on some patients. This is a study asking the question, does cancer occur more frequently? Are malignancies found more frequently in patients who are transfused? And they looked at patients 5 years later after transfusion. Clearly in this study, there was a higher incidence of certain tumors. And the interesting thing to me, as somebody who's interested in the immunobiology of transfusion, is the cancers where there's been a strong association between recurrence at the time of cancer surgery, such as colorectal cancer, renal cancer, the more immunologically manipulable cancers are also higher, suggesting an immunological source for at least some of these tumors, that these patients had been immunomodulated and made them more vulnerable to developing cancer in the future. And if so, that's not good news, obviously. We don't want to be increasing the risk of patients having cancer. And I think this is our own data, and it's in acute leukemia, acute myelogenous leukemia. And we have found that patients who have pretty good risk leukemia, younger patients, who are given wash transfusions, another modality for reducing immunomodulation, have strikingly better survival than other patients treated at centers that do not use wash transfusions. So this is based partially on a randomized trial and partially on observational data, but we think this is clear evidence that, in fact, transfusions do immunomodulate patients and increase the risk of recurrence of both leukemia and solid tumors in some cases, and may, in fact, be modifiable by such modalities as washing. So this is just a complex model that Ken Remy and a couple of other pediatric immunologists and intensivists put together for publication in Transfusion a few years ago. And it shows some of the theories about how transfusion both increases immune suppression, but also increases inflammation. And we could call this immunodysregulation. So allogeneic transfusion, but not autologous transfusion, seems to be a very powerful and negative influence on clinical outcomes. So in summary, transfusions predispose to postoperative infection, sepsis probably, cancer recurrence, lung injury, inflammation, multi-organ failure, and clearly thrombosis, since there's a randomized trial showing allogeneic transfusion increases thrombosis in some patients, and that by using restrictive or bloodless technology or approaches, or autologous transfusion as part of bloodless medicine, are going to be associated based on randomized trials with reduced morbidity and mortality. And this is one of the reasons that Jehovah's Witnesses, in studies by Dick Spence and others many years ago, witnesses who do not want transfusion as part of their care actually have better clinical outcomes. And Aryeh Shander, pioneering his work at Inglewood Hospital, showed that when his witness patients were treated with their multimodality approach, they also had better outcomes. And in fact, their open heart surgery program had the lowest mortality and lowest best clinical outcomes of all the programs in New Jersey when it was implemented. We know that for patients who will accept transfusions, that we can modify some of these unfortunate effects by leukoreduction and by restrictive transfusion. And the work that I've showed you that's come from our center has been the work of many, many people, including Dr. Rafai, who just spoke, but I'd like to particularly acknowledge my co-leader of our research group, Dr. Joanna Heel, who is also my wife and has made an enormous impact on the work that we've done. Anyway, I'll stop there. Thank you very much for your patience.
Thank you so much, Dr. Bloomberg. Like just a note for everybody, please have, like, we will have a question answer session at the end of the next presentation. So if you have any questions, please like in the QA box at the bottom, like you can write your questions there, or just hold on to your questions till the end of the next presentation. So next, I would like to invite Dr. Carolyn Burns as our keynote speaker for today's session. Dr. Burns has been the medical director and the chief of pathology at the Jewish Hospital Healthcare System Department of Pathology in Louisville, Kentucky. She is the current president of the Society for the Advancement of Patient Blood Management, and she is a passionate advocate for patient blood management and has published many articles and textbooks on this topic. And she's a prolific speaker, and she's sought for speaking at many PBM societies and conferences, and we are so lucky to have her here. So she's going to give the keynote address, which is Patient Blood Management and Bloodless Medicine, State of Science and State of Art. So Dr. Burns, all yours.
Thank you. Thanks, Gagan. Really appreciate it. And thanks to Dr. Rafai, Dr. Bloomberg, who gave such excellent talks and have really kind of teed up a whole lot of what I'm going to be mentioning today. So let me go ahead and share my screen, pull my slides up, and we will jump right in. Okay, let me get my display different, and you tell me, Gagan, are we good to go? Can you see my screen?
Yes.
Wonderful. So thanks again very much. It's a real honor to be here as the keynote in this SABM BMSS session. This is a very special meeting for us and a very special thing that we do through our Memorandum of Understanding with the Bloodless Medicine and Surgical Society. So I would be remiss if I didn't thank each and every one of those folks that were on that planning committee and are part of BMSS for making this happen every year. And I was not able to attend the last 2 days due to other commitments, but I've been watching the social media and the things on LinkedIn and WhatsApp coming through, and it sounds like it's just been fabulous, and attendance has been wonderful. So we're getting the message out, right? So when I started to talk with Nat and the rest of the committee about this particular keynote, I was having these thoughts in my head recently about how medicine has changed over the course of my 30-some years in practice and ultimately in consulting. And I was really starting to think about, where are we with the state of the science, as we would call it? Where are we state of the art? How do we, in a sense, for those Star Wars fans, how do we Vulcan mind meld these Star Trekky kind of thing? How do we do that? Are we doing it well today, or are we not? And how does patient blood management, comprehensive patient blood management, and bloodless medicine as a part of that, how does that fit with where we are currently? So that's where I'm going to go today. A little bit of philosophy and a little bit of science to, again, kind of round out what our previous two speakers have discussed. This is my obligatory disclosure. I will not be discussing any of these entities. Important at the bottom is my email. Always feel free to get a hold of me to further discussion, ask questions. If you'd like some PDFs of some of the articles that I'm sharing, please do so. So again, I'm going to define what I see and what, the Webster's Dictionary would call state of the science and state of the art, and kind of discuss those concepts of then where we are with our evidence-based care versus what I'm going to call narrative-based care. And I'm going to illustrate then, I hope, to you how I see PBM and bloodless medicine and surgery truly reflect these principles and practices. So some of you know I'm big on words. I used this slide at the annual meeting when I was presenting the global definition. And it comes from being deeply rooted in a home with an English teacher, as many of you know. And my mother used to tell me, you need to choose your words. Words are very important. They represent you, your character, and the concepts that you're trying to project and potentially have people embrace. And I think it's very important when we use our words then, and I love this particular quote by John Birmingham, who was a British author, words matter and the right words matter most of all. So if we consider those words in terms of state of the science, if you go to Webster's or you go on Google, we can see that state of the science means this is that current condition or our current position where we have a system base of our knowledge that we've garnered through our physical world, through our expectation. We try to do unbiased studies, whether they're observational, cohort, retrospective, or randomized controlled trials. That's our state of the science. And we've seen the state of the science in terms of transfusion, optimal blood use, and bloodless medicine and surgery, patient blood management, all coming really into the forefront since about 1999. And Neil mentioned that very landmark study of Hebert and his group out of Canada, the first randomized control trial ever done in the arena of transfusion medicine. So that's our state of the science. This is evidence-based, right? This is where we go and we read the literature and we try to adapt that literature to our own practice. Now, if you talk about state of the art, what does that mean? And how does that fit into our medical practices? Well, state of the art, I think of, I would imagine you do too, I think of technology, right? I think that's the most recent, the latest and greatest, the highest stage of development, right? I can tell you, I just got a brand new, let's pretend I just got a brand new TV, and it is state of the art. It's got all the whistles and buzzers. So these are the technologies that we have our fingertips in patient blood management and bloodless medicine and surgery. Whether those are minimally invasive procedures, robotics, our use of new topical hemostats, or other pharmaceuticals, cell salvage equipment, all these technologies are state of the art. So we have as well with state of the art, even though it uses the word art, it still in a way is science because we look at that by definition as technology. So let's go even simpler. Let's kick ourselves back to the art of medicine. And we all, when we're healthcare providers, know that we are here to practice good science, good evidence-based medicine. But have we lost the true art? And art is that expression, I love these words, of application and appreciation, especially through our senses. So this brings that patient-centered expression, application, appreciation, where we're using our senses predominantly, right? We're using sight, touch, and hearing. We see our patients, we look at them, we listen to them, we examine them. We sometimes, absolutely, yes, we can smell them. And back in the olden days, I remember when pathologists used to dip their fingers in urine and taste it to check for sugar, diabetes. Mercifully, we don't do that anymore. But what we're doing is we're using our senses. And this is the basis of the art of medicine. So if you look at the art of medicine defined, again, words, this means we're becoming human again in our approach. We're using what we'll call narrative-based medicine. And that involves us listening and looking at our patients. And what I loved about this definition is it says we're understanding their perspective without any judgment or being too quick to respond. I know many of you probably do like I do. When I was seeing patients, I would go in and I'm hoping I'm listening to them, but I'm sure what was going on in my brain was sometime I was listening to what they were saying, but I'm already clicking the top 3 in my differential diagnosis, right? And I'm already making, in a sense, a little judgment about what they have. What is their disease and what am I going to do about it? So we need to step back and allow that narrative base our senses to be really used to the fullest. So we provide patient-centered care. So this is where PBM and bloodless medicine and surgery fit. It's the perfect example of patient-centered, patient-oriented, narrative-based care, right? To actually practice PBM and also those bloodless medicine and surgical techniques, tactics, whatever we want to call those. It demands that we combine our state of the science, our state of the art technologies, and provide the narrative-based care. So it's a perfect example of what we need globally. And that brings us then to the global definition, right? And many of you have already seen this. We discussed it at the annual meeting. It's also published officially in the September themed issue of Anesthesia Analgesia. But notice the words. Yes, we are using a systematic evidence base. Yes, we want the latest and greatest in the science. We have to come full circle with where the literature speaks. We cannot turn a blind eye to that science. But notice where we're talking a lot about then applying that science to the narrative so we provide patient-centered care, improved patient outcomes, preservation of the patient's own blood. And this means patient safety and patient empowerment. They're becoming part of our team. And we all know that in patient blood management, as Sabam describes it, we have our 4 pillars, right? We have diagnosis and management of anemia, optimizing hemostasis, minimizing bleeding and blood loss, interdisciplinary, multidisciplinary conservation techniques to preserve the patient's own blood. And the 4th leg of that stool is patient decision-making, right? We can't have the 3 legs do what they need to do without that 4th. So I love the fact that the authors, the group that worked on this definition, they really focused on these words and forced us once again to come back a little bit more into the art of medicine. Now, we can all say, we know we have barriers to this. We talked about this as well. Professor Hoffman brought this up at the annual meeting. Why do we have these barriers for implementation of PBM around the globe? And yes, it is very difficult. As you can see in this quote by Dr. Roberts, weaning us off of our love affair with blood is no easy task. And that means that it shows us that we are complacent in our way we feel. We use blood. Our dogma is very tenacious. It's very hard for us to give it up, right? We've done it for years and years and years. So it's what we do, isn't it? We have a lack of knowledge and education surrounding not just transfusion, but all of the additional aspects of comprehensive patient blood management. And we, as healthcare providers that are here today in this virtual room, we need to be pushing this message, take that science and move that forward. We have to use that to try to combat this lack of willingness to change. And we have that. We dig our heels in, and we have to start opening our eyes, opening our ears, and coming back to that art. Now, I will be fair that I want to say too, that PBM is not an easy thing within your institutions. Those of you that do it and do it well know you've probably had a long journey with infrastructure. This is why Sabam is a multidisciplinary, multi-professional group, right? We know it takes doctors, it takes nurses, it takes laboratory professionals, it takes pharmacy, it takes administrators, it takes perfusionists, it takes all of us to make this work. And those of you that do it well have that infrastructure. Those of us that perhaps are on the struggle bus a bit, we need to work on this. And it's very important. And I will say that means we have to challenge ourselves to change. So if we look into some of that literature, that state of the science, and already Dr. Rafai, Dr. Bloomberg had talked about these things. And here's another visual that shows us, and these are things we can share with our colleagues who probably or maybe are not quite there yet to start getting into patient blood management. Maybe they don't understand those concepts quite yet. They haven't read the science. Well, this is a beautiful visual from Dr. Spons, and thank you, Dr. Spon, for allowing me to use this. And I really think it drives home that message that when we reduce, when we limit or eliminate the need for red cell transfusions in particular, but we'll see it mirrored in the yellow stuff, Yes, we reduce the number of transfusions. That's good. That's great. We want to do that. But where the rubber hits the road is we're removing those complications. We reduce acute renal failure. We reduce the infection rates that Neil just spoke of. We reduce those thromboembolic phenomena, which, by the way, our University of Rochester folks have published on. We reduce mortality, and we reduce the length of stay. So all of these things go to improving our patients' outcomes. If you want to look at it another way, you can share some of these citations with your colleagues as well, or if you haven't read them, please do. It really speaks to the fact that liberal use of transfusion is not necessarily providing better outcomes for our patients. And in fact, we're very often doing that harm. And this is in a dose-dependent way. And Neil brought that up, unit for unit for unit. And we see it in surgical patients as well as in medical patients. And if you look at just the surgical arena, you can see for every single unit that we transfuse, we increase wound infections, length of stay, ventilator dependence, pneumonia, thromboembolic events such as MI. We heard that just a few minutes ago. Stroke, DVT, PE, and increased mortality. Unit for unit. Serious infections in our medical patients as well. And just a recent article in Critical Care that I got just probably 2 weeks ago speaks to an increase in 1-year mortality of those who survive their ICU stay when they are transfused. And Dr. Rafai just beautifully represented their paper where they showed that RBC transfusions are not improving O2 delivery and or tissue perfusion. So these outcomes, these matter. In the themed issue of anesthesia analgesia, 2 additional studies. Look at the top one by Trentino. These are our Western Australian colleagues, that even a single unit causes more hospital-acquired infections and increased length of stay and readmissions. Readmissions is a serious issue for most of us in our hospitals. And I think I would say most of us, we don't want to see our patients bounce back. I want to see patients I've seen, maybe at the grocery store or at church or out walking their dog. I don't want to see them back in the hospital. We want to think our patients are leading, healthy, quality lives. For each unit, we increase this. And then, of course, in the CV surgery arena, we're seeing that increased odds, again, of post-operative infections. So are we doing harm when we receive these? And what I think is very important is if you look at that ANA issue, Dr. Gooby has the forward at the beginning, her editorial, and she mentions these articles and says it really gets us going down even a different paradigm. I think we've all been bandying about this notion of why give 2 when 1 will do. Well, as she very nicely states, it begs the question of why give 1 when none will do. So let's think about that. If we have otherwise stable patients, can't we be intervening without transfusion at all? If you want to see some literature, mirror image of red cells, let's talk about the yellow stuff. Platelets, notice, increased nosocomial infections, no clear benefits even in patients with intracranial hemorrhage. Actually increases those outcomes and mortality in patients when we treat them, even if they're on antiplatelet medications. When they get peri-procedural prophylactic platelets, increased bleeding, increased admission to the ICU, and prophylactic pre-procedure platelets increase that risk of thrombosis and mortality. And that is our Rochester colleagues' literature. That's their state of science. Plasma. Plasma, for those of you that know me, you know I am a bona fide, self-proclaimed plasma phobe. I don't think that there's very often any reason to be using plasma. Very, very few circumstances. I think it's the most misunderstood and misused product that we have. But notice what we're seeing now in this literature. Increased infections, increased multi-organ failure, increased adult respiratory distress syndrome, increased morbidity in our oncology patients, increased odds for red cell transfusions as a surrogate of bleeding. We're actually increasing bleeding when we provide plasma. And then worse outcomes in terms of both mortality and neurocognitive outcomes in patients with traumatic brain injury. So we're seeing the literature, the state of the science with the yellow stuff catching up with where we are with the state of the science with REDS. And all of these things definitely could be due to those immunomodulatory effects, storage effects, just like have been presented previously. So if you haven't seen the study, you may have earlier in this past couple of days, but it's worth reiterating if you have seen it. I think this is a very important study because we've taken a step back from just randomized controlled trials of a restrictive hemoglobin threshold versus another. We've got tons of RCTs with those in a variety of patient populations in both neonatal, pediatric, and adult patients. So enough, let's dispense with those. But tell me about these non-transfusible versus transfusible patients. And in this particular systematic review and meta-analysis, non-transfusible, by the way, is not just those that are non-transfusible because of their religious faith. It also could be non-transfusible because you have a patient with an unusual blood type or who's alloimmunized to a degree but that you can't procure blood for them. It's not available. So what do we do with non-transfusible patients? We go down the road of bloodless medicine and surgery. We think outside the box and we figure out a host of ways to support them. And we know they will do fine. And this study actually showed that those that were non-transfusible versus those that ultimately could be and would accept transfusion had no increase in mortality. They had lower length of stay in the ICU and actually trends toward decreased infections, acute myocardial infarction, reoperations, and lower hospital costs. Now we're going to get the elephant out the room in terms of cost, because all of us as clinicians, we hate to talk cost, but we have to realize we need to be fiscally responsible. And any of us that are in tight resource areas, whether we're low, middle, or high resource countries, we all have our issues with those resources and how we're going to spend our dollars. So if we can lower those costs and provide better care, that's being fiscally responsible, and we can funnel those dollars back into care within our communities. So it's really a win-win. Now, I would imagine that Dr. Frank presented his latest data. This as well is published in the themed Journal of ANA. And I think it drives home the message again, and Neil brought this up too, that bloodless medicine patients do as well, if not better. I can tell you in my own institution, I didn't publish, but anecdotally, our bloodless medicine patients, our patient blood management patients did as well, if not better, than those that received transfusions. And when we limited those transfusions, we found that as well. So here's Dr. Franks and the Hopkins group where they had their bloodless medicine patients compared to those of standard care. Morbidity and mortality were comparable. So we're not doing harm by not transfusing, right? We're taking our state of the science and applying it so we limit or eliminate that need for that transfusion. And actually there were trends toward lower M&M in the patients that were bloodless care. And once again, they showed some lower hospital costs. So they're saving money that they can funnel back in. So that's the economics of the issue. And that's where we need to be taking those dollars and applying them to where we need for our communities. So Steve was very kind to allow me to share his chart. You've seen it. It's worth looking at again. We've got blue is for bloodless. We've red for standard care. And notice the differences in terms of the percentage of patients and that composite morbidity and mortality. One of the best things I found in this particular article is the pull quote from the discussion. And again, it drives home the message. We're using the state of science, we're using state-of-the-art technologies, interventions, but we're bringing back the narrative of care. We're bringing back the patient decision-making, patient autonomy, where medical providers respect and honor patients' wishes to receive or not receive specific therapies. We should be considering this in all of our patients, which without regard to what kind of treatments we're proposing. We give our patients the choice of their chemotherapy, the choice of their surgery, the choice of blood, no blood, or other items. So we bring that narrative care back. I'll also share with you, this is an article by Isbister et al. This is the Australian group, and they published their article in the themed journal. And if you want something to really drive home the message of narrative care, your personal art of your medical care, read this article. It really focuses on the person that we're treating and how we're going to focus with patient blood management by evaluating them, managing any of those blood abnormalities, whether that's anemia or coagulation abnormalities. We're going to try to minimize or avoid allogeneic transfusion whenever possible. And we do this in the backdrop of that patient-centered education. And I will say also educating their families or other caregivers that they have, and making this the team effort to provide them both continuity of their care, inpatient as well as outpatient. So a wonderful publication that really draws us back into our art of medicine. So we get back then to this whole idea of, yes, we want the state of the science, we want the state of the art, we want our narrative-based care to ring out and bring everyone around the globe to understand this urgency for patient blood management. And I think the WHO policy brief that came out 2021 really states this, that we have an epidemic of anemia with over 1 billion people affected worldwide. And let me put that in a little bit different statistic. If you look at some of the other statistics that are done, it really speaks to the fact that probably within each of our own regions where we practice, probably 1 out of every 3 to 4 people are suffering from anemia. So that means if I look at my 2 kitty corner neighbors in my neighborhood, the 2 couples that live on either side of me, that means 1 out of them has anemia to some degree. And that anemia, by the way, read an interesting article just the other day that put it in this perspective. The disability or the decreased quality of life associated with anemia is greater over the years than the combined disability or decreased quality of life from those that suffer combined diabetes, cardiovascular disease, and asthma. Wow. Anemia has lower quality of life over years compared to all of those diseases combined. And Dr. Rafai mentioned that right out of the gate, how this affects our patients. The most common etiology, yes, is a simple nutritional deficiency, right? That many of us can easily correct. Maybe others not so easy due to resources, but we have to look at this nutritional deficiency. We also, as the policy brief points out, we have roughly 600 million people that have some form of congenital or acquired bleeding disorder, which causes them to have acute and or chronic blood loss. And that is going to contribute to that anemia burden. So we have to, again, take our state of the science, our state of the art, our narrative-based art of medicine. We have to start saying to ourselves, anemia is bad by itself. Coagulopathies are bad in and of themselves. Transfusions are bad. So now we put them all together, and what do we have? The great trifecta of not goodness. So let's get back to this urgent need for PBM and our bloodless medicine and surgical approaches to our patients. And this is what will compel us to move our own practices forward. It will challenge us to change, help our colleagues change, and move forward with this PBM as the global standard of care. And when we take that state of the science, state of the art, and our narrative-based, our art of medicine, it really gets us back to this quote by Dr. Peabody, way back from 1927. We can treat a disease. We can go check, 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 check. Think all you want about that disease. But when you personalize that care, you patient-focus that care, the care of the patient is personal. And I think that's where PBM fits. I think it exemplifies it. It is everything we do in patient blood management is that. It's making it completely personal. So thank you very much. I really appreciate the opportunity to be with you, and I'm very honored to be a part of this session and to be a member of BMSS as well. So we'll await the questions, answers, and discussions. Thank you very much.
Thank you, Dr. Burns. Thank you so much for a wonderful presentation, as usual. So we will now do the Q&A portion. So if you can drop any questions you have in the Q&A section, and we will ask as many as possible. And any ones that we can't, we will answer in the chat as we move forward. So our first question is when determining what transfusion alternatives to use on a bloodless patient, what can help to identify genuine products from fake? If any of our panelists want to address that first question.
It might help to clarify, what sort of products are being asked about.
Yeah.
I think pharmaceuticals are regulated very differently in each jurisdiction, each nation. So in the United States, the FDA, if something's FDA approved, it had to go through some sort of process, whereas many of the non-FDA approved herbal and similar substances, there really is no control. I think it's very hard to know what's a legitimate product and what's not in the United States.
Okay, thank you. And we'll move on to our next question. And again, any of our panelists that would like to address it, so someone wants clarification on the statement, why give one when none will do?
Yeah, great. Okay, let's go back historically, and we can say that back in the olden days, when I first started practice, we used to think that if you're going to give red cell transfusions, you should never give just a single unit. It won't do anything for you. You have to give 2 units. And I'm sure probably those of us that are of my vintage and older, we remember the days that, particularly as pathologists and in charge of transfusion services, I used to send the nasty grams, right? The letters to anybody that did single unit transfusions to say, bad doctor, right? If you were going to transfuse, you should give 2 units. Well, now, obviously, we've come 180 degrees, right? And we know that unit for unit gets poorer outcomes. So we started doing this mantra of why give 2 when 1 will do. And we've been seeing that out in the patient blood management and optimal blood use world. That's been kind of one of our slogans, if you will. But now that we're continuing to see that dose response with even a single unit transfusion in our medical and our surgical patients, it begs that question of why give even 1 when we don't need any? So, why, just because someone has a hemoglobin of 7 and they're otherwise stable, why do we feel compelled to give a unit at all? Well, could we be looking at the etiology of that anemia and treat it in a much different way, even in the critical care arena? So that's really the emphasis, is do we need to even walk ourselves back from 2 to 1 to none?
Okay.
So let me raise a point as a panelist. Clearly, there are issues associated with even a single or perhaps even a half a unit, as some may use to try to avoid taco. I'd like to ask Dr. Rafai, he gave a wonderful presentation. Could you comment on the possibility that there's a change in the microcirculation associated with the delta in your PaO2? There have been some very nice studies that show that when one transfuses, if you look at the microcirculation, you may actually impede flow and close up areas of perfusion. Could you comment on that?
Yes, absolutely. I mean, I saw that study and they
Let me just mention that the person asking the questions.
I'm sorry?
Okay, I was just trying to say that was the past president of SABM, Dr. Art Briggs.
Okay, thank you. Thank you. It's a very good question. Actually, I did look at that study myself, and I did see they have actually a video of showing you how the red blood cells move in the capillary vessels, the patient's red blood cells versus the transfused red blood cells. Absolutely, because of the changes in the red blood cells membrane, these red blood cells become less elastic. I mean, it's very hard. It's the viscoelasticity of these red blood cells become very hard and becoming as if like you are moving a non-changeable cell, which we did see on that video. I wanted to include that video in my presentation, but just because of the time and the links of the video. But actually it's available if somebody wants to find it. you can see how the red blood cells stuck, and that's may also explain what Dr. Blumberg mentioned in one of the studies, that patients after transfusion may have increase of stroke or increase of MI, and also we know that's one of the red blood cell transfusion complications is thrombosis. So that's definitely, it's a reason for it. Now the oxygen exchange, absolutely, by slowing this movement of these transfused red blood cells, that will be one effect. The second effect is the biochemical changes in the cells itself, in the hemoglobin itself. So the oxygen itself will add another reason for why these patients has less oxygenation and why these patients are not improved when we transfuse them.
Thank you.
Also,
again, it's been an excellent session. Sorry, I was just going to say that the two, I've been monitoring for the 3 days, and it's been a wonderful session. I want to thank the organizers for putting on such a great work. Thank you.
Thank you.
Okay, we have an additional question, and we're actually going to address this to Sarah first. Do you have difficulty getting health insurance to pay for alternate therapies to packed red cells, blood, if the patient isn't refusing blood products? For example, Epogen, tranexamic acid, IV iron, etc.
Yeah, I can only speak for the location and in America. And there is a little bit of a difference between the acute care setting and the outpatient setting. So first I'll deal with the hospitalized patients. In the United States, the way that hospitals are reimbursed for care is a bundle payment. And so they can treat the patient however they want. And so, no, we don't have any problem with ordering up our therapies to optimize blood count in the inpatient setting. When we move to the outpatient setting, it does get a little bit more difficult. And there are times that it is very difficult to get an ESA. The patient most likely has to have some form of bone marrow suppression or kidney disease involvement, or you're going to have a little bit of a battle getting that approved or paid for. And so sometimes, like in the case of CV surgery, it really is incumbent on the organization to look at what's best for the patient, and do we eat the cost of ESA? Does it make sense? Are we going to better that outcome or save money when they come to us in the inpatient setting for their surgery, just to eat that cost? That is one solution that I've seen used, but often if it's bloodless care, you kind of have a little bit more leeway. But again, if they accept transfusion, it can be difficult in the outpatient setting.
Can I add one more thing here to Sarah's comments? As she just mentioned, inpatient shouldn't be a lot of issue, and sometimes we eat some cost. For outpatient, we have our anemia clinic here, and we give them iron infusion for any elective procedures. That's if we have enough time. And we were able actually to talk to the insurance company and indicate why we are thinking about fixing this anemia before they get admitted. And they were very helpful. They right away approved it. And although it's going to cost them a lot of money, but they understand it's one complication of red blood cells may exceed the inpatient lengths of stay, or maybe even cause some ICU admission. So they were 100% with us on this, and we had a lot of patients who got transfused either once or twice infusion of iron before they come for an elective procedure. So that was very helpful.
Yeah, I think I'll add to this little round table here. I think it's very important, yes, that you work locally with your coverage determiners, because they can vary from state to state to state. I mean, I've worked with some hospitals here in the Commonwealth of Kentucky that the insurance carriers will not allow some of those IV iron preps outpatient or inpatient. You know, the pharmacies have to choose just one, and they have no leeway or it won't be covered. So it kind of depends on where you live. And I think that the Eastern Corridor has been much more proactive in this and much more successful than we have perhaps here in the middle of the United States. And I don't know if that is the same over in the EU or Africa or Australia, if you all have those same variations of coverage based on your demographic.
Any additional questions or comments at all?
Yeah, hi, this is Art. I've got another question for the Honorable Dr. Blumberg, and that is, what do we know about the effect of transfusions on Tregs or other regulatory cells at the mechanistic level?
Thank you, Art. There's some things known, but actually most of the research in animal models and in patients was done in the 1980s and 90s. Not much has been done since then. We know that allogeneic transfusion, but not autologous transfusion in patients, and the equivalent in animals would be allogeneic versus syngeneic. That when you give allogeneic transfusions, they cause immune deviation towards type 2 responses or Th1 responses. We know that they stimulate Tregs. So if you're looking at absolute numbers of cells, which are mostly what are looked at, and in fact, that's a problem because obviously we're interested not just in number, but in function. Classic example in peripheral blood would be platelets. You can have patients with platelet counts that are a few thousand that have better hemostasis than patients who have platelet counts that are 100,000. So, but if you're looking at cell number, both T helper cells, type 1 immunity, cellular cytotoxicity are decreased, and Tregs and type 2 immunity are increased. And this has been most clearly shown in animal models.
Thank you.
Okay. So we have another question that was also sent, and the question is about given IV iron before surgery. So saying for a patient whose transferrin is below 20%, and they do not have enough iron for erythropoiesis, and they would benefit from IV iron. But we also know that epogen will help override the hepcidin suppression and help support erythropoiesis and optimize hemoglobin. What is the timing that you should administer IV iron prior to surgery? Is 6 weeks prior still optimal? Dr. Arthur Bracey, would you be available to?
Oh, sure. Yeah. So, I'll take that one. Yeah, 6 weeks. It's definitely optimal to load iron in advance of surgery. Now, clearly, one of the things that's an underlying principle is that in order for ESAs to be effective, you have to have an adequate iron content. So giving ESAs in an iron deficient state will yield really minimal to nil with regard to a load of increasing the RBC mass. One can give intravenous iron, even as short as perhaps 2 weeks, but it's really preferable to get to your patient much further in advance, remembering that it does take time to replete the RBC mass. So it's recommended that anywhere from 4 to 6 weeks would be optimal in terms of iron loading. The other caveat is to make sure that when you're looking at iron studies, that you don't get fooled. Sometimes patients have, in essence, anemia of chronic illness, and so there's release of ferritin from the storage cells. So if you look only at ferritin, you may think that your patient is iron replete, but in point of fact, if you look at other measures like TSAT, if it's less than 20%, you can see that there may still be a role for iron therapy.
Thank you. And Tanisha, did you have a contribution or comment anything you needed to add?
No, I'm good. Thanks.
I see Professor Rowland's hand up. Like, if you can unmute yourself. Yes, please.
Yes, thank you so much for giving me the opportunity. I want to commend the organizers. This has been an exceptional day. Professor Rafai's presentation, Professor Blumberg's presentation, and finally Carolyn Bond's wrap-up of the whole presentation in her keynote address. All the presentations deserve a standing ovation, actually. But like Carolyn said, there is a huge gap, global gap in the awareness and need for PBM. And it would certainly take a lot to win doctors of their love affair with blood. And it's going to be harder than we think, as she quoted Ian Roberts. I think sessions such as this are really, really the pathway to ensuring that the huge global gap in awareness is short. And in most of the third world countries, it will be a long while before they have alternatives to full blood transfusion because of lack of the technology, as she noted, which we need to make the change to the challenges we face with blood transfusion. But it's been an exceptional occasion, and I feel very fortunate indeed to be able to attend. So congratulations to all the presenters. Thank you very much.
Yeah. Thank you so much, Professor Rowland. And I'll add to this. I think also it's going to be very important. I see going forward that some of the groundswell for patient blood management will be through patients. When they start being educated, they start asking for it. When they go to their care providers and start asking, as we say, ask the 50 whys. Why do you want to do that? Why could we not do this? And I think if we get patients, again, involved with that care, we might start to see a little bit more traction, as well as when we educate ourselves as providers and our colleagues and our healthcare systems, whether it means you have a healthcare ministry or we have to go through insurances like we have to here in the United States, and getting that message to those types of folks. So we start to get almost a bit of top down, pushing that out as the better bundle of care, and also at the same time, saving those precious resources. So thank you. Thank you for your comments.
So Dr. Burns, Art here. So I'm in my car. That's why I've had my video black. But what's actually been, I'm going to add on to what you said. So I've been participating in one of the restrictive transfusion trials, the MINT trial. It's very interesting because when you approach a patient and you start having a real discussion with them about whether they would like to receive a transfusion, they don't want the transfusions. And so what's pretty clear to me is that the process that we use now to obtain informed consent is basically just asking folks to sign the line and we will transfuse you, as opposed to proper informed consent. So I think it's really important that we really try to stand up patient choice, because we do a poor job at it.
Exactly. And we discussed that a little bit at the annual meeting, because one of the cases I presented was my best friend who had a very severe traumatic fracture in her arm. And by the way, she was a blood banker and she was my prior patient blood management coordinator. And literally the nurse walked in the room, as any of you that attended annual meeting know the story. The nurse walked in the room and basically held up a piece of paper and said, you need to sign this to get your blood transfusion. And she's going, what? What are you talking about? What? She didn't even know. No one even came and talked to her about even where her hemoglobin was. So you're right. And I think we've also had the opposite, interestingly. If you try to change care, I've had some cancer patients that have been used to getting their standard transfusions, right? And now your hematology oncologist comes in and says, we're not going to need that. Well, then the patient thinks you're giving up on them and said, what do you mean you're not going to give me my transfusion? So I think that's another part of the essence that we have to be able to talk to those patients so that they don't feel we're changing their modality of care because we're giving up on them. What we're actually doing is changing that care in order to make them better. But that sometimes I've been in a room with a cancer patient when we had to discuss this because they really said those words, where you're giving up on me. No, we're not. And so we go back and really work at that with that. That's part of the communication that we have to have with our patients. It's that art of medicine. It's the narrative.
Thank you.
Thank you so much, everyone. So I would like to thank you all our speakers this morning, Dr. F.A., Dr. Bloomberg, and Dr. Burns, and all the panelists and all the attendees for active participation in all these presentation. So if your questions have not been answered, you can go check the QA box. Like some of the questions might have been answered right there. And now I'll hand over the session for the next session to our moderators for the next session, Kevin and Sarah.
Yes. Well, we'd like to welcome everyone to our final presentation. It's hard to believe that these 3 days have gone by so quickly. And my name is Sarah Walbold. I am the RN coordinator for ProMedica Health Systems for bloodless care and patient blood management. And I'm honored to have a co-moderator, Kevin Wright, who is also program manager of the transfusion-free medicine and surgery at Rhode Island Hospital in Rhode Island, USA. Kevin?
Good morning and thank you. Nice to be with you, Sarah, of course.
Yes, you too.
And, good to see everyone this morning. Looks like we have a little over 250 today. We've had a peak so far of just over 300. So this is outstanding. And it really shows the enthusiasm and interest in this important topic. Thank you. So we welcome everyone, and everyone's been very enthused, as has our speakers and presenters. Now, in addition to that, we've had wonderful questions. I did note that one comment I think I would just add, there was a mention about the need for published data, and published data is available. Appreciate Dr. Bloomberg mentioning that if we send him directly, he will give us information, but also other data is available. So just ask. Additionally, some have been wondering about presentations being available, and I think you can write BMSS directly. We'll make that email available again. So keep the questions coming, keep the interest, because it really helps us all, and keep your comments as well. So we really appreciate it. Following such an incredible morning of information, we'll now give our attention to, and I'd like to introduce and give you some background on Mr. James Reynolds. His topic is the making of First Do No Harm, a documentary on the history of blood transfusion. But let's just learn something about Mr. Reynolds. Very interesting. I've had the pleasure of knowing James for some time, but he's worked as a documentary producer and writer with National Geographic channels worldwide to produce a documentary on the Samaritan rhinoceros, which are acutely endangered in Southeast Asia. His company worked in collaboration with established content providers and distributors such as TV3 Malaysia, Australian Broadcast Corporation, Beyond Distribution Australia, and the Watchtower Bible and Tract Society. Reynolds was the director, writer, producer of the documentary. I think we all enjoy that, First Do No Harm, which won Oscars as well. Oscar acquired the script of the documentary for their permanent core collection, so forth. He's also served as an ex-advisor to the Beijing Red Cross Blood Center, Peking Union Medical College Hospital, and the former China representative for the Society for the Advancement of Blood Management. So as you can see, he's had a lot of experience, a lot of exposure, and it's really helped us all. So we're going to give our attention to Mr. James Reynolds, and we look forward to your presentation.
Thank you very much for that rousing introduction, Kevin. I believe my recorded presentation is already with the organizers, and so I might just request them please to hit the play button, and then once we finish the presentation, I'd welcome any questions.
Hi, I'm James Reynolds, and I'm the director of the feature documentary Primum Non Nocere. First, do no harm.
Before 1900, doctors had not understood why some transfusions caused bad reactions and even death. Landsteiner thought there might be different kinds of human blood. From studying these results, it was found that there are 4 different kinds of human blood, or 4 blood groups. Landsteiner's discoveries solved one major difficulty standing in the way of successful blood transfusion, but another remained.
Blood was highly coagulable. The addition of citrate helped maintain the blood in a liquid fashion. Russian physicians pioneered the collection and storage of cadaver blood.
A triumph in the study of blood is a new test that detects the mysterious Rh blood factor.
There are probably hundreds of blood types.
The push to separate whole blood into its individual components really started blood banking.
Blood plasma, a recent and important discovery of medical science, provides a permanent bank for use in transfusion. Furnished by volunteer civilian donors, the blood plasma may be stored indefinitely and given to any patient without risk. Thousands of men and women are donating blood for the Red Cross National Blood Bank to furnish plasma for emergency transfusion.
Researchers are now looking frantically for acceptable and plentiful substitutes for plasma.
Instead of the traditional, easily breakable glass bottle, whole blood to be shipped is today enclosed in unbreakable plastic containers.
Dr. Cooley has done thousands of cases of cardiac surgery without transfusion.
All these men down here, they only get $5 a pint for their blood, but we're striking this blood bank.
You had virtually 100% chance of acquiring hepatitis B from being transfused.
We're going to have 1 million outpatient visits a year from AIDS and AIDS-related illness. I will do all that God gives us the power to do to find a cure for AIDS.
But now we know every one of us could be devastated by it.
That they had a medication that was infected with the AIDS virus. They took the product off the market in the US and then they dumped it in France, Europe, Asia, and Latin America.
Every time we make blood safe, that step is going to add cost and at the same time may not guarantee us complete protection.
If you get my blood, you will now have my DNA.
So we are dramatically expanding the use of DNA evidence to prevent wrongful conviction.
For the first time in its history, the National Security Council got directly involved in combating a virus, HIV.
The government's scientific committee recommended the use of a filter for transfusion. When is the government going to react to that recommendation?
That recommendation is obviously very important for the future of the blood transfusion service. I will look at it very carefully and I'll get back to him. 200 million units of donated blood are needed worldwide.
80 million transfusions are administered each year. The shrinking donor availability means global blood resources are in short supply.
I'm joined by Richard Melcheth, the former Executive Director of the Society for the Advancement of Patient Blood Management, and my co-producer. It's been 10 years since the release of the documentary. It was shortlisted for the MIP-TV Asia Super Pitch Awards in 2011. Let's screen the teaser.
When it comes to blood transfusion, it seems as though we have not really understood, in that we've never done the basic research to know when we're doing good and when we're doing harm.
Transfusion alters a lot of things in the organism, and it has long-term side effects.
The recurrence rate is anywhere from 2 to 3 times more recurring cancer if you give blood than if you don't give blood. So that's a very frightening situation for those who go for cancer surgery.
You give a bag of blood, and the bag of blood has all sorts of things in it, and you ignore them.
Blood transfusion has never undergone randomized clinical trials to the level at which a new drug would have to go through the FDA. It's never been done.
Many clinicians think of blood and blood components as a drug to treat specific conditions that patients have. In fact, blood is an organ. It happens to be a liquid organ. This happens to be the only transplant that all you require is essentially a couple of letters behind your name and a pen, and you can write for it.
They know not what risks and benefits they're likely to create or cause as they give this therapy. They've been essentially brainwashed by a public relations event that's gone on since their birth.
И в Америке, и в России есть врачи, ретрограды, которые за то, чтобы переливать кровь. И есть те прогрессивные, которые говорят, что надо все больше и больше отказываться от переливания крови. А критерии к этому, наверное, это точно, и у вас, и у нас сейчас одни и те же, которые вытекают из доказательной медицины, что надо отказываться от переливания крови.
Every decision I make as a physician should, you would think, be based upon my in-depth weighing of the evidence of I'm going to do more good than harm if I take the following therapy.
Avoidance of transfusion, as well as or the possibility of reducing exposure of patients to allogeneic blood certainly helps, if you will, restore some confidence by patients that they're going to get the best care.
We as physicians have all taken a very basic oath, and that is the Hippocratic Oath, and it's to try to do good for mankind, and it also has the corollary of first do no harm.
Richard Melcheth, welcome. Together with the Society for the Advancement of Patient Blood Management, we worked on projects in China and Malaysia between the years of 2009 and 2012. With our superlative crew, we conducted and shot interviews in China, Finland, Ireland, India, Chile, Puerto Rico, Hawaii, and the United States. Why was this such a Herculean task?
The film was intended to provide a global perspective because transfusion is global in practice, and thus the challenge is global as well. So professionals in medicine, surgery, ethics, blood banking, from the United Kingdom, Greece, Germany, Australia, Russia, Nigeria, the Philippines, China, Japan, India, and the USA were interviewed. And it was fascinating to learn their stories and the events that shaped their current practice into closer alignment with scientific evidence and patient safety.
Richard, was there one interview that you conducted that really impacted you?
The interview with Dr. Slapoushkin, an anesthesiologist from Russia, I thought was most revealing. His experience working with miners in Siberia, where access to blood was limited, and yet those with life-threatening blood loss survived.
Let's watch that sequence together.
Произвел уникальную операцию, то есть невозможно было достать шахтера, он произвел ампутацию одной ноги, одновременно обезболил этого шахтера, одновременно ввел кристаллоиды внутривенно, а надо все это понимать, что это в условиях шахты, где пожар, где все падает. У него одна лампочка на лбу только, которая освещает. 10 часов. И этот шахтер потерял более 75% объема циркулирующей крови. То есть критически. И тем не менее он 10 часов прожил, этот шахтер. Его лечили, и через месяц он, правда, на одной ноге, но тем не менее он здоровым ушел домой. Уникальный случай, и за этот случай вот этого врача Руслана правительство наградило орденом. Вот в том числе и из этого случая я тогда сделал вывод и начал задумываться о том, что а зачем переливать кровь? Если человек прожил без переливания крови определенный промежуток времени, много часов, то какой смысл ему в дальнейшем переливать крови? Я не вижу этого смысла. И с тех пор, наверное, я начал этими проблемами заниматься в научном аспекте.
Let's see why the Semmelweis sequence is one of the most important in the documentary.
In the early days of asepsis in Vienna, Austria, Dr. Semmelweis noticed that the midwives had many fewer infections than did the physicians, who often were touching many different patients or even actually coming from the morgue.
The docs would go from the autopsy room into a delivery room, didn't change the gloves, didn't change the coats, didn't wash their hands, just went from one table to the other. The physicians had a horrible death rate related to post-delivery sepsis of the moms. Same population of moms, midwives were delivering mothers, their death rate was much less. Semmelweis goes, well, why are they having less sepsis, less illness and morbidity? And made the simple observation that you need to wash your hands between patients. He introduced that idea to his team and said, okay, here's what we're going to do. We're just going to wash. Just use regular antiseptic solution and wash, and his moms started surviving at much higher rates. There was no basis for anyone to believe him, plus he was a pretty colorful character apparently as well. And what he was suggesting just sounded outrageous, even though he did have evidence. He had data.
Las observaciones de Semmelweis son observaciones de sentido común, son observaciones de la vida diaria, son observaciones de alguien inteligente que está tratando de ver algo. Y sin embargo, en su tiempo fueron rechazadas, objetadas y su autor perseguido.
He was drummed out of the business, basically, because it was not traditional. The influence of the politics and the fraternity of medical professionals at the time was such that it was simply unacceptable to consider that anything so simple could be the reason for the difference in survival.
People are actually thinking it is all due to demons or devils coming in, till a simple solution Semmelweis brought in of hand washing, and that prevented all this sepsis. So that's a simple solution. So many things in medicine may have a simple solution, but people are reluctant to accept because something is simple.
The Semmelweis principle is the knee-jerk rejection of anything new because, again, it challenges the norms.
Now that evolution of that thought of, well, there's a connection here, can I improve outcome, could actually translate into what happens in transfusion.
It serves to illustrate the bias that we physicians have, which is that we really truly believe in what we know, in the way things are done now. And it's the biggest challenge, I think, to practicing physicians, to always be aware of and awake to the possibility that something better is coming along, something new and different, maybe even something contrary to what we believe is the right thing to do. We have to always be open to consider a new idea, even if it flies in the face of everything we think is true.
So again, the Semmelweis reflex describes the rejection of evidence because it doesn't agree with previously held views. It's unconventional. Also, the simplicity of a recommendation causes it to be ignored. And Semmelweis was up against the politics and the fraternity of medical professions at that time. So is there a parallel today? Could the Semmelweis reflex describe the reaction to bloodless medicine and surgery principles today? Well, interviews with several of the doctors echoed the same observation. They thought so.
Dr. Jonathan Stamler recently said, it's apparent that transfusion is associated with significant risk of morbidity and mortality, including heart attack, renal injury, and death. How does this statement tie in with the title of the documentary?
First, do no harm, part of the Hippocratic Oath taken by physicians, we believe framed well the need to evaluate and to revisit why doctors do what they do. And blood donation and transfusion, while popular, emotional, and considered a very noble life-saving endeavor, merited a rethink in the light of emerging scientific evidence. And so first, do no harm, what ethicist Professor Ken Kipnis refers to as the first principle of healthcare, better describe the aim and underpinning approach for this documentary.
One of the most powerful revelations for many was Professor Stamler's groundbreaking research that banked blood is deficient in nitric oxide. It cannot vasodilate effectively to deliver oxygen. Let's watch that sequence.
Hemoglobin doesn't just ferry oxygen from lungs to tissues and CO2 back, carbon dioxide back to the lungs, but it carries this third gas, nitric oxide, in a protected form, and it releases the nitric oxide together with oxygen. The nitric oxide then dilates the blood vessels so that the oxygen can get to the tissues. What turns out is that our blood banks are deficient in nitric oxide. When you store blood in the blood bank, the red cells lose their nitric oxide, and they are therefore unable to dilate blood vessels, and oxygen delivery to tissues is thereby impaired. So the world's blood supply is deficient in nitric oxide, and those red cells do not seem able to deliver oxygen in the same way as a fresh red blood cell is capable of.
Another point, is bloodless safe or safer or more efficacious than blood transfusion therapy?
In order to ensure that the right thing is being done, there should be a basis in fact for what the therapy or the intervention is going to be.
This concept of tradition-based practice and evidence-based practice is quite the rage right now in transfusion medicine for the trauma patient.
There are data in the literature to suggest that even transfusing patients bleeding from trauma leads to adverse outcomes.
When we study groups of patients that have been transfused, they have a higher incidence of such things as infections after surgery, recurrence of cancer, lung disease and lung problems. Now, it's very tempting for all of us to then say, well, so it's proven, it's a cause and effect. But just by the way that kind of medical research is done, you cannot call cause and effect. However, let me point out to you that there is a place in the world where we've made that association, and we have never done controlled randomized trials, and that's smoking.
What cigarette do you smoke, Doctor? Tens of thousands of doctors in all branches of medicine, in all parts of the country, were asked that question. What cigarette do you smoke, Doctor? The brand named most was Camel. Yes, surveys show more doctors smoke Camels than any other cigarette. Smoke Camels, the cigarette so many doctors enjoy.
Does anybody watching this film have any doubt that smoking is related to lung cancer and emphysema? Yet, we've never taken two groups of patients, given them cigarettes or not, and said smoke for 50 years and let's see who comes out better.
Can we give a transfusion and not hurt you? Can we do a clinical trial and demonstrate that a transfusion is no worse than not giving a transfusion? Or that you can transfuse more and not make you worse than transfuse less? No one has ever said, let me give a transfusion and show that you could do better. No study is designed like that.
Transfusion medicine suffers from not having a well-founded scientific basis for the use of the therapy.
When doctors don't know whether what they're doing is harming the patient or not, okay, they have an obligation to find out. You've got practical disagreement among clinicians, okay, and yet one remains inside the standard of practice and the other is outside of it. Okay, so how do you settle it? A randomized clinical trial.
Richard, let's go back to why we produced the documentary.
The purpose of this documentary was to learn how blood transfusions became embedded in clinical practices without the rigors of testing. For example, randomized controlled clinical trials to really measure its safety and efficacy. The primary audience was the public, and really worked to explain in simple, clear, as well as accurate ways the development of this fascinating therapy. And secondarily, but not any less important, was the medical community, who already understands much of this, but not always in the framework of first do no harm.
What are the implications of becoming a blended animal, a chimera?
There's been a number of studies shown that if you give a blood transfusion without reducing out the white cells, and still in the United States 50% of our blood is given without reducing the white cells, you will become what is called a chimera. You will become a blended animal. You will no longer be a single, distinct human being. You will be a multi-DNA'd animal carrying somebody else's DNA. How long? We don't know, but it's fascinating from the World War II group of veterans that still, some 50 years later, they still carry the DNA of the person that they were transfused from. We know today that a number of rare diseases are carried in your DNA. Your propensity for getting lymphoma, leukemia, something else, cancers may be affected by this. Your transmission of this may lead to any number of other diseases moving through a population. It's never been studied, nor do we have the foggiest notion about the effect of blood transfusion on what we call the epigenetics, the movement of these genes through a population.
Have audiences benefited from the documentary? Dr. Ji Hong Wen, head of China's National Patient Blood Management Initiative, in a total of 26,000 hospitals nationwide, recently said, PNN has been played many, many times, not only in the Chinese Society of Patient Blood Management congresses, but also in many other circumstances. It really helped people in China, especially doctors, understand the risks of transfusion and how bloodless medicine works. It has made a great contribution to China's PBM program. This year, the National Health Commission of the People's Republic of China has released guidelines for perioperative patient blood management. It is a health industry standard in China. We have made much progress with PBM. Thank you, Richard.
Remember when China's Ministry of Health created the Department of Blood Management, and now Professor Xi leads this initiative in over 26,000 hospitals in China. China loves bloodless.
Richard Malcheff, thank you very much for your insights on the making of the documentary. In addition, I'd like to thank our investors, our outspoken interviewees, and talented crew for giving audiences access to a red-blooded story of life-saving importance. And we'd like to thank the organising committee of the Bloodless Medicine and Surgery Society for this opportunity.
Thank you very much for that presentation. James Reynolds, I was so impressed with the story of the miner who, it seems like every time blood is not an option. And we see, that's when we really get to look at, you know, what will be the outcome of not using blood. And even though he lost 75% of his blood mass, he went home healthy in a month. That was very impressive. Does anyone have any questions or comments about it or the presentation we saw?
Sarah? Sarah? Oh, hi, it's Carolyn. Sorry, I had to move my location. I was getting an echo, so I apologize.
Yes.
Is there a way to get a copy of this video to be shared in our own communities, or is it to be purchased? How do we do that?
Dr. Burns, when that video was released 10 years ago now, a SABM committee actually reviewed it for scientific accuracy.
Okay. Yeah.
And we had an agreement with SABM, if we had any commercial success, which we didn't, that a portion of the profits would go to SABM for furtherance of education purposes. So you can actually download it on the Bloodless Medicine website. We do have a higher resolution, of course, but because of the data flow, we gave a low resolution for the presentation. But I believe Dr. Uzro can certainly give you a link to the full documentary, the 90 minutes.
Okay.
Of course, it's 10 years old now, so there may be some things that are slightly out of date, but still packs a punch.
Yeah, it's still very salient. It still has its message, and so that's.
I believe so.
I saw it looked like everyone was far younger. So, but and that was prior to me getting really involved with SABM. So I will double check and I will look, because I think this could be a powerful thing to push back out. Thank you so much.
Well, we could recut it. We could certainly recut it and update it. It was long. It was lengthy. Back then, our objective, of course, was to enter it into the Oscars, which it was entered into. So it had to be of a certain length, and it had to be featured in cinemas in the United States, which we were able to do.
Excellent. Great. Thank you for sharing that.
Oh, it's a pleasure. Thank you for asking me. It's come out of the wardrobe. What's fascinating, though, is that for the first time during, I had no knowledge that this documentary had the results it did in Malaysia. Dr. Jamela said that was one reason why she kicked off with patient blood management yesterday, and I was quite surprised about that. And I see Professor Sunji Karamoto there, and he was very helpful for not only an interview, but he featured the documentary in 2019 at a ASPBM Tokyo meeting. So it's been the rounds, and it still seems to be making some headway.
Yes, indeed. And I think that the conversation is a great time. We are living in a fascinating time, I think, for patient blood management, where we've got global conversation going, and we have, so is it time for another documentary?
Well, this could certainly be streamed down, and with all the data available now, I'm sure a very good documentary could be made. And now with the knowledge, the wide knowledge of anemia and the effect that this is having on
You know, the figures have been different over the last 3 days. I've seen a figure of 3 billion who are anemic, iron deficiency anemia related to that. And then today there was an outstanding figure of 600 million. That's 600 million individual lives that are impacted by anemia. And you think, you know, goodness me, the disease can be treated. It's not as though it has to, you know, or is it expensive? And particularly in developing countries in Asia, we have that very serious situation.
Absolutely. And I see that someone shared the YouTube link for this documentary. Thank you, Bruce Zangle.
We'll post the making of that too. That was a real pleasure. And Richard Melcheth, we had such an outstanding crew. It was a very difficult labor of love. It took us 2 years, and we dragged ourselves over the coals to produce it. It was featured at the Cannes Film Festival as well, where they didn't really know how to take it. We were interviewed by a number of news outlets. They coined the David against Goliath story because, you know, the behemoth here was the blood industry, a multi-billion-dollar industry worldwide. And so the Society for Bloodless Medicine and Surgery and SABM are going up against a pretty strong adversary in some respects, of course, if you want to call them adversarial. I suppose I have to choose my words more carefully in the future.
Dr. Su, would you like to say something? Would you like to comment?
Hi, Louis Su, pediatric hematologist from Chicago. Thank you very much.
I've heard your lecture before, Dr. Su. Outstanding.
Fascinating.
Oh, thank you. I think that to do an update of the documentary would be a great idea, because part of the credibility of showing it is that it's, you know, evidence-based, and how much you need to keep up with things would really be important to do.
I agree.
You have a specific point, Dr. Su?
Yeah, I had a little bit of a chat about one is the chimerism and the white blood cells. So in the United States, most of the red cells, I believe, are now leukodepleted, so you avoid that problem. And so it does not ring true at all for my patients.
Actually, I heard the figure yesterday that, well, Professor Spieth said only 50%. So I don't think the FDA has mandated, have they, that the leukocyte be depleted from the red cells?
No, they
in the
haven't.
US?
This is Neil Blumberg. That's correct. But Dr. Su is correct. It is not 50% any longer. It is probably estimated somewhere between 90 and 95%, but nobody knows. But the point's well taken. Nobody has ever really shown that microchimerism after transfusion has any clinical consequences. So that's one thing. And with all due respect, while nitric oxide is very interesting and very important, clearly nobody's ever shown that renitrosyl renitrosylizing transfusions. Dr. Stamler had I believe had a study that he was doing to see if restoring nitric oxide could improve clinical outcomes. And, you know, those data are not available either yet or ever. And so until you can show you modified clinical outcomes, I think it'd be important to emphasize, for example, use of autologous transfusion techniques, cell salvage, where there are randomized trials showing improved clinical outcomes, and that these are things that are adaptable in many settings other than, you know, the high-tech, high-resource parts of the world. So I think if I were remaking the film, I would emphasize bloodless medicine, patient blood management, and its improved clinical outcomes as delineated, for example, in the recent issue, September issue, I believe, of Anesthesia and Analgesia. And I would kind of de-emphasize the scientific things that are still of interest, such as the chimerism and nitric oxide, but have not yet really yielded any clinical benefits to patients.
Fascinating discussion. I think that we may be a little over on time, so should we turn it back over to Gagan?
Yes, thank you very much, everyone. I think at this point, if there were no further questions, it looks like we're going to be heading to the annual general meeting. But we want to just thank everyone, our presenters, and such. We still have over 200, nearly 240 in attendance. So obviously the enthusiasm continues. And James, really, it's good to see you and to be reminded of that outstanding presentation. I think there's general consensus that it's time for a redo. So we'll look forward to no doubt further information in that regard. But we want to thank everyone, and outstanding conference, scientific conference, the presentations, information. And that's actually going to close our session for this morning. And what we'd like to do now is call on Dr. Carolyn Burns to introduce the annual general meeting.
Hello, everybody. Okay, so I take it this is where we get to finalize our time together. And Nat, maybe I should ask you, how would you like to proceed?
Thank you very much, Carolyn. Actually, most of us here are both SABM members as well as Bloodless Medicine and Surgery Society members. So I think Kevin was thinking that we are in SABM when he called on Carolyn. Thank you, though. Thank you for passing it on to me, Carolyn. And please let me use this opportunity to welcome everyone warmly to the annual general meeting of the Bloodless Medicine and Surgery Society. Please do not leave. First of all, let's take a little poll here. Let me see. Yes, I have just launched a poll. And the first question there is to choose your continent. So please see if you can choose your continent, so we know where we're all coming from.
Is not responded.
The hosts cannot vote, it looks like. The hosts are unable, the panelists.
Oh, the panelists can't vote. So it's the audience then. The audience can say where they came from. Okay. Seen quite right. We'll give a little bit of time for that. Okay, so it looks like yeah, so the second question is, have you attended BMSS annual meeting before? And then we have some responses there. At the end, I'm going to show all of us the results of the poll. And we said, choose all that apply to you. So if you're having more than one option, please go ahead and choose. BMSP, HLC, hospital administrators, lawyers, medical lab science, nurse, pharmacist. Is there no pharmacist here? I think I had some pharmacists writing to us. Then, are you happy with the caliber of the speakers at the meeting? Are you happy with the quality of the scientific content? Are you happy with the focus of bloodless medicine? Are you happy with the duration of the talk? Do you want it shorter? Do you want it longer? Duration of the session, want it shorter, want it longer? And would you attend BMS events in the future? And would you invite others to attend BMSS events in the future? Those are all the questions we have. And I can see that, yeah, right. I think we've got, let me see. Okay, there are still some responses coming. So while people are responding, let me once again thank all the speakers today, all the moderators and panelists, and all speakers for the entire meeting, the moderators and panelists too. The Sabum session was really outstanding, and I'm very, very happy that BMSS has a relationship with the #1 PBM society in the world, Society for the Advancement of Patient Blood Management. Okay, so let me see, I'm going to end the poll and then figure out how to publish the results. Aha, so I do have an option of sharing the results. Is it showing up on your screen?
Yes.
Right.
Yes, it is.
So you can see that 63% of us are from Africa. Sadly, no outpost of BMSS in Antarctica, but we do have in Asia, Australia, Europe, North America, South America. So we've got to head to Antarctica. But it's gratifying because one of the panelists pointed out that said that we don't have some of the technology that the Western societies have in Africa or in developing countries. It then means that we need bloodless more than most others in the world. We need to be able to do without blood transfusion. And it's good that we are the majority here. In any case, BMSS is based in Africa for now. Have you attended BMSS annual meeting before? It's almost like half have attended before and half have not attended before. That is also gratifying. That means the numbers are increasing. Choose all that apply to you. So the HLC, HIS make up the majority here, while the physicians, that's great, are next. And then others and nurses, med lab science. How come no pharmacists here? We had pharmacists last year, so please, we need to spread the message to pharmacists. This is a multidisciplinary society. I'm sorry, so we didn't add perfusionists. There's supposed to be perfusionists also. We'll improve on that poll. Are you happy with the caliber of the speakers at this meeting? 98% said yes. And 2 people said no. Okay, so we'll be happy to hear from them, maybe by email. I think we'll send out a survey. Kevin had prepared a survey for us. So we send it out so they have opportunity to say what they do not like. Are they like overqualified or what? Are you happy with the quality of the scientific content? There's only one person that said no. Again, we would love to hear from that person so that we can improve. Are you happy with the focus on bloodless? Could it be the same person saying no? Because there's only one person. 99% say yes. Okay, so perhaps it's actually the wrong meeting. Are you happy with the duration of the talks? Again, only one person said no. Want it shorter? Well, some want it shorter, some want it longer, but the vast majority, 94% said they are okay with the duration. So we'll go with the majority. Are you happy with the duration of the sessions? Again, 98% say yes, and 1 person said no. 9 people wanted it shorter, and 4 people wanted longer. Okay, so we still go with the majority. Will you attend BMSS events in future? Well, all said yes, including the person that wants the quality improved. So we really need to take that comment to know how we should improve it. Would you invite others to attend BMSS events in future? All said yes. And we are very grateful to you for sharing your thoughts. Zoom is going to store this poll for us, and we'll use it to improve ourselves. So once again, welcome to the annual general meeting, proper Let me see if I can share my screen so that you take a look at the agenda. I think this is it. Okay. So here we are. I promise you it's not going to be long. It will be very brief indeed. That is the agenda. Welcome. Then minutes of the previous meeting, review of BMSS 2021, BMSS 2020, that is the meeting where we are now. We'll say a few words about it, and BMSS 2022 award, BMSS 2023, that's next year, and then adjournment. So are we happy with this agenda? If so, can one of the panelists move for adoption of the agenda?
I move to adopt.
Thank you. That was Caroline, right?
That was Sarah Wobble.
Oh, Sarah. Oh, wow. Okay. Thank you. And who is second?
Second.
Okay, please, could you mention your name?
Sharon.
Oh, okay. Thank you. So Sharon is second. And I think the third is Dr. Burns, but normally there's no third. All right, so we'll go on to I've already said the welcome, and the next item is the minutes and action points from the last AGM. So our esteemed secretary, I think, is going to take us through that. She was in another meeting. Let's see. Okay, she's back. She's around now. So she is Dr. Ananthi Krishnamurthy. Over to you, please.
Hello, everybody. Thank you for staying on until now, and it's been a great meeting. So I shall just quickly go through the past minutes, and I'll just share the screen. Can I share? Yeah, okay. Right. Okay, so I believe you all can see the screen, right? Okay. All right. Okay. So this was the AGM was held last year, 5th of November, 2021. And parts of the minutes was chairman address, and also the previous minutes. It says that at the time, basically chairman, Dr. Osoro, actually explained about the beginning of the BMSS, and it was actually in Zambia. And discussion was in 2011, and by 2014, the society was already on its feet. And the first annual meeting was in 2015. And in 2019, BMSS received a certificate officially, right? And since in 2020, because of COVID pandemic, then since then, the conference and all has been on Zoom. And it has afforded us a greater attendance and a greater share of speakers. So this is great because, well, without the pandemic, then we all may not have the opportunity to gather together, right? Like this. All right. So the next point was actually a review of 2020 by Dr. Okoawo. And so they have mentioned for the first time in BMSS in 2020 had a virtual annual conference. And in day one, there was 292 participants, and that was huge for BMSS. Day two was 300 plus, and day three was 240. And so the quality of presentations was great, and it was a huge success. Wouldn't be possible without a physical meeting. And subsequently, the review of 2020 by Dr. Isiguso. Also, he mentioned that the 2020 conference gave a foretaste of what 2021 will be like. Well, for 2021, there was a variety of topics and plenty of practical aspects. And also there was some of the topics he mentioned was liver surgery and easy postpartum hemorrhage management. And it says he mentioned that it actually demystifies the myth. So he appreciated the collaboration with SABM, and he recognized and thanked everyone for their contribution. As for the past meeting, the BMSS award was actually presented. The Award of Excellence for 2021 was presented to Dr. Stephen Frank, and he is a well-deserving leader in bloodless medicine and surgery. And at the time, Dr. Frank too acknowledged and showed much appreciation for this privilege. Well, we closed the past year's meeting, making it like BMSS to be slotted for November 2nd to 4, 2022. And here we are today at November 4, 2022. Yeah, so that's a great achievement indeed. Yes, so can I ask for any questions about the minutes? No questions?
Thank you very much, Ananthi. So questions to Dr. Krishnamurthy, please. Or
not a question, but a thank you. Very, very nicely done, and a very helpful timeline of events for BMSS.
right.
Thank you.
I agree with Kevin. So instead of questions, maybe we can say, are there any matters arising? Any issues? Ananthi, did you see any issues that we need to address? You can go ahead and address them. I think you addressed some of them, like you said, here we are in BMSS 2022. Is there something else we needed to do that you need to let us know that we did?
Yeah, I'm just wondering who's receiving the award this year. Yeah.
That one is a secret until we get there.
Right.
All right. So thank you very much, Ananthi. I think the next item is a review of BMSS 2021. And we have the chairman of BMSS 2021 here with us, who would share with us some highlights of the events that he chaired. That is Dr. Chimobi Isiguzo. You need to unmute yourself, please.
Thank you for giving me an opportunity to review last year's conference. The next slide. Okay. The event held between 3rd and 5th of November 2021, and I was privileged to chairman it. And the team focused on safety and quality of care as drivers of bloodless medical care. The whole presentation centered on safety and quality of care as one of the achievements of bloodless care. The first day was graced by a keynote address from Bruce Price, who brought to the front burner the COVID-19 and blood safety, the elephant in the house. That presentation left us with many questions to answer about the use of blood, especially in the light of the pandemic. We also enjoyed the third Arya Shanda lecture, which was ably handled by Steve Frank, and it was entitled Safety and Quality of Care as Drivers of Bloodless Medicine. On the second day, we had case-focused presentations on bloodless care in sickle cell disease, especially in the pediatric age group, liver surgeries in Japan, open heart surgeries in US, and application of bloodless medicine and surgery principles in private settings in our resource-poor region. The third day spotlighted bloodless medicine programs, the challenges, the weaknesses, and the strengths. We also enjoyed the nursing role and their perspective in bloodless care. We had a total of 4 abstracts, and they focused on case reports on pure application, practical application of principles of bloodless medicine, and also enjoyed some KAP studies on bloodless medicine and care. With respect to the attendance, it had a worldwide involvement. We had attendees from all continents except Antarctica, and we're hoping that one day we'll have attendees from Antarctica. This is actually the statistics. Day one, we saw 518 registering, with 255 attending. That was a 49% attendance rate. Day two, we had 573 registrations, 292 attended, reflecting 51% attendance rate. And day three, we had a higher number that registered, 581, 246 attended, and that was a 42% attendance. We concluded the whole session with an AGM and adopted this year's team, that's the 2022 team. As a word of review, the content was quite rich. It was also inspiring. It left a lot of us more determined to continue to advance the course of bloodless medicine and surgery. Since then, we have noticed more practitioners who are joining the train or joining our big family. There are some who are on our blog today who were not there last year. We have also noticed many people, many practitioners being more ready to discuss their experience with bloodless care. We also saw a wonderful support coming from SABM. We felt it and we appreciated it, and we are doing the same. We are also enjoying the same this time around. That's a brief report. Thank you very much.
Thank you, Dr. Siguzo, for that nice report. Again, I don't know if we have any comments we want to make on that report. Please, you can raise your hand if you have a comment to make. So if there are no comments, the next item on the agenda is BMSS 2022, which is where we are now. And already we had a poll that might indicate some of how we feel about the conference, but we are still free to comment on it. We can start with the panelists if they have comments on the past couple of days of this annual scientific conference of Bloodless Medicine and Surgery Society. Nobody's raising their hand. I will have to appoint people. Let's hear from Dr. Su, what he thinks. Dr. Su has spoken at our meeting before, I think last year, yeah. And it was really fantastic. So he's here this year, and he can compare. Are we doing worse? Are we doing better? Are there some things we need to improve on? Dr.
This is very good. It's getting better, and I like very much the evidence-based. The pace of it is good, and the time zone works for me in North America.
Thank you, sir. Let's hear from Rebecca Rock. I'm sorry about I keep using first names, but in SABM, we're a family, a very, very close-knit family. So Rebecca Rock, she's a nurse running a blood management program in Canada. And,
yes, hi. Are you able to hear me? Yeah. I'm
Yes,
joining.
very well.
Thank you. I'm joining while I'm trying to get into work. But no, this meeting was excellent, and I think that when we listen to a lot of the messages that the speakers gave, we've got the science, we have the discussion of the art that that Dr. Burns had shared. It really does appear that in order to advance this, we need to be collaborative. And I greatly appreciate having organizations like Bloodless Medicine and Surgery Society align with and collaborate with SABM, as well as NATA and IFPBM and our other partners across the world. So I certainly encourage more collaborations like this, more opportunities to have meetings like this in which we share our knowledge and share our successes and also our failures, so that way we can learn from each other and continue to advance this for the benefit of the patient. So very well organized. Thank you.
Thank you very much, Becky. Does anybody else have a comment they want to make? Yeah, Tanisha, she may have something to say this time. Tanisha Davis.
Yes, well, thank you for inviting me. Thank you for inviting me to be a panelist. That was the first time that I got that opportunity to do that. So I appreciate it. I really appreciate this conference. Last year was the first time that I attended, and comparing last year to this year, I thought it was still very good quality. My team members did have the opportunity to attend some of the sessions, not all of them. So I'm super duper appreciative of the fact that we can go back and see the recordings, and we're going to use that as part of our lecture series because we have so many new team members in one of my acute care facilities. So thank you for the recordings. What I like to suggest or think about is, because I'm thinking about my new nurse practitioner, she's not that familiar with EPO and the dosing, and she's very, very nervous about the clots. But we did start to have her educated on that. So I think I would appreciate a little bit more information about that. And then also if we had an opportunity, maybe some of the people that are here to discuss very, very difficult cases, kind of like a Q&A. And if maybe some of us can present those cases and maybe how we mismanage them, and to get advice from this panel on how we could have managed those cases better with some suggestions, I think that that would just be awesome.
Don't go away yet, Tanisha. James, bring her back. So I think Tanisha raised a few points that have gotten to me. You may have gotten others. Number one, she talked about people she shared the invitation with. And I think that is an encouragement to us. Please, when we get the invitations, let us share with as many professionals around us as possible. It's a multidisciplinary society, so all the medical people and that work with or outside of Bloodless, we should invite them so that we don't end up talking to ourselves. And we want to improve on the attendance. This year, I can let it out that in excess of 1,000 registered, was 1,080 as of yesterday, last night. And we've been having attendance between 300 to 500. The actual number is maybe more than that, because some people are using linking up to 2 devices and so on. So let us share the invitation as widely as possible. The other thing is she talked about an interactive session, a Q&A sort of thing. So we do have another meeting in the year. The Bloodless Medicine and Surgery Week comes up in May. Usually incorporates the World Bloodless Surgery Day, which is May 16th. So that is a forum in which we can easily incorporate that. And Tanisha, I hope you join us and make that become a reality. We'll send you a membership form. I think you're already a member. I'm sorry.
I think so.
Anyway, we'll check on that. Yeah, I think you filled out a form. And tell us where you work. I know you're managing a bloodless program in the US. But
Yes.
Which center?
So right now, I'm the administrative director for RWJ Barnabas Health System for the patient blood management programs and the transfusion-free medicine and surgery programs for the system. So we have 13 acute care facilities. Right now, the goal is patient blood management process for all of the health systems. So there's some things that all of the sites get. And then there is one site in particular that has a fully comprehensive patient blood management and transfusion-free medicine and surgery program with staff. So we call it that's the campus with boots on the ground. So it's about seven individuals at that campus. And then at our level 1 trauma center, that campus has transfusion-free medicine and surgery there. And they also have about 4 people running the program there. So we're trying to see exactly how we're going to continue to extend blood management throughout the campus. And then we're trying to figure out what do we want to do with transfusion-free medicine and surgery, because every campus doesn't need a site, but maybe we can do, a region in the north, a region in the south, and a region in central. We're still trying to figure that out.
Thank you very much, Tanisha. So I can let you go now. And before we move on to the next item on the agenda, let's allow some of the members of the audience to say something. I think there are a few hands up. There's Kumalu. Could you introduce yourself and say something? Could you unmute yourself and say something, please? Okay, while you're still trying to do that, let's hear from Timothy. Timothy? Okay, Timothy is, okay. Komado is here now. Could you introduce yourself and say something, please? Yeah. I'm sorry, Komalo, we can't hear you well. So you can.
Okay.
You can.
Good
okay,
afternoon. Yes. Good afternoon. I just want to say thank you very much. I enjoyed this course very, very much. It was very informative. The speakers were well prepared. And really, I think there is no ways to really describe how grateful I am to have been able to join this virtual meeting. I'm looking forward to the next one, and I'm so grateful. I just want to thank you very much to the organizers and everybody involved in making it a success.
Thank you very much. Let's hear from Agri. Agri? Could you unmute yourself? Okay, maybe he's not here. Oh, he's here. Okay, go ahead, Agri. Introduce yourself and say something. Okay, looks like he's having a challenge there. Elizabeth Nwaso. Could you unmute?
Yes, thank you so much. I want to join the other speakers to congratulate Professor Usoro and the organizers of this meeting. I think I have really enjoyed being part of it. I've listened to the keynote address, I've listened to the Arya Shanda lecture, and really it's very encouraging to note that there's so much research going on and that we don't really need to give as much blood as we are giving. And I can attest to that because in recent times, in my current practice, we hardly ever have to transfuse any patients. And our transfusion triggers are now so low. We don't even, sometimes with HBs of 8, we are still able to do elective surgery and get the patient up and about in a little time with the methods of blood conservation and all that we are doing. So I want to say kudos to the organizers. I want to say that, I agree with somebody who said that we need to share the message or share the information about the meeting to more of our spaces. And I just want to say congratulations and well done, and thanks for all the good job you're doing. Sorry, I didn't introduce myself. I'm Elizabeth Waso. I'm a professor of anesthesia. I work at Ahmadu Bello University Teaching Hospital, Zaria, Nigeria, but recently I've been working in Saudi Arabia for the past few months. Thank you.
Thank you very much, Elizabeth. I was going to introduce you because I could tell from the voice, the surname has changed. So Elizabeth is the professor and she's determined to make me a professor. I'll get there. Yes. Thank you though. So please, could the others put their comments in the chat for lack of time, or in the chat, not Q&A anymore. So please, I crave your indulgence for us to move on to the next item on the agenda, which is the BMSS 2022 award, which is a high point of this meeting. And with your kind permission, I would like to share a little bit on what the award is all about. So that is okay. Right. So the BMSS Award of Excellence. You might have heard during the introduction of some of the speakers that they had received the Award of Excellence of this society. So this Award of Excellence was instituted in 2015 during our first annual general meeting. And the award is for an individual or an organization with a track record of outstanding contributions to the science and practice of bloodless medicine and surgery. The awardee must have a track record of outstanding contributions to the science and practice of bloodless medicine and surgery in any or all of the following areas: academic, clinical, or advocacy. And I'm trying to advance the slide. So our awardee for this year is James Reynolds, whom you were just listening to a while ago. James Reynolds has worked as a documentary producer and writer with National Geographic channels worldwide, and his company worked in collaboration with established content providers and distributors such as TV Malaysia, Australian Broadcast Corporation, Beyond Distribution Australia, and the Watchtower Bible and Charity site. Reynolds was the director, writer, producer of the documentary. I won't read the Latin, I'll read the English. First Do No Harm, which he was talking to us about how he produced it during this meeting today. In 2013, the Oscars acquired the script of the documentary for their permanent core collection. Reynolds served as an ex-advisor to the Beijing Red Cross Blood Center, Peking Union Medical College Hospital, and he was a former China representative for the Society for the Advancement of Patient Blood Management. His previous endeavors was to organize international congresses of healthcare professionals that disseminated information related to patient blood management and bloodless medicine and surgery. He also assumed the responsibility of coordinating with healthcare professionals, governmental and non-governmental organizations. Following countries, you can see them listed from Australia all the way to South Korea. Incidentally, let me mention that James Reynolds is actually from Australia, but he has been all over the world. I actually met him in the US. And at this moment, I think he's in Thailand. So you can see how far and wide he has been traveling. And wherever he goes, he has a passion for bloodless medicine and surgery, even though he's not a clinician. These initiatives have had a significant impact on reducing allogenic blood transfusions, but most importantly, improved clinical outcomes, especially in China. I think everybody in Asia knows James Reynolds when it comes to patient blood management, bloodless medicine and surgery. And at this meeting, he just presented the Art of Bloodless Medicine, the making of First Do No Harm, the documentary on the history of blood transfusion. I placed the link to that video in the chat. So in case you missed it, you can check again. And so, ladies and gentlemen, that is the awardee, the person that is being awarded. I'm sorry, let me do. The connection went off, and I don't want to be interrupted. So it's James Reynolds that is receiving the BMSS 2022 award. And let me assure you that the award is not just electronic, it's actually physical. This is it. And so, ladies and gentlemen, I present to you the awardee for 2022 of the Bloodless Medicine and Surgery Society Award of Excellence, James Reynolds. Perhaps we give a brief opportunity for him to make some comments. James?
Now I know why you wanted me to stay on. Goodness me, I had no idea this was coming. It's a great honor. Thank you very much, Dr. Uzra. And I'm not a clinician. I've never pretended to be. I was catapulted into this many years ago in Malaysia when we were there, my wife and I, and we had the great pleasure of watching the alternative strategy, simple, safe, and effective, broadcast on national television there. And as a result of that, the Watchtower organization in New York received dozens of calls from physicians and the blood bank actually requesting the use of that video so that they could train their doctors to avoid transfusion because of the high rate of infection through HIV, AIDS, and hepatitis. So this was a field I never expected to work in or have the pleasure of working with so many very fine people and extraordinary people, quite honestly, who've made such great sacrifices to help their fellow man. We saw that particularly in China, where when we went there to distribute the programs, the Chinese government picked up on these programs and said, we need help. We're in a desperate situation with the infection rates of HIV and hepatitis. And they looked at bloodless medicine and surgery as an answer to a problem that was so complex and so overwhelming that now they have implemented in or are implementing in over 26,000 hospitals. And it's not for religious reasons. They're a communist country, so atheists by persuasion. And so they're doing this out of the best interests of their people, their populations. And of course, we saw Dr. Jamella's outstanding presentation in Malaysia. So this bloodless medicine and surgery has been a great advocacy. And I am very fortunate to be given this award. It was something that never crossed my mind for a minute. So it's just been a great opportunity to basically help our fellow man, quite frankly, and help improve situations that are beyond most people's control. So thank you very much for this, Dr. Uzra and the Society. I don't know what more to say. I think I better disappear.
very
Wow.
much, James. And be assured that we shall ship your award to you. I'm sure the audience is clapping for you already.
Well, thank
So
you.
with that, yeah, you're welcome. So the final item on the agenda is BMSS 2023. So again, let me see about sharing my screen. Probably have just one slide on that one. Right. Right, so that is what we're looking forward to next year, BMSS 2023. I'm sorry, the date was not typed in there, but I can tell you it's going to be November, because our meetings are always in the first week of November. It's going to be November 1st to 3rd. Let me see if I can quickly do that. So that you have it in there. November to 3. Right. So November 1 to 3, and the theme is compassion at the heart of bloodless medicine. So is there any objection to this, or is anybody in agreement? If you agree with this, please move for adoption of this theme and the dates. I think I will have to rely on the panelists because
I agree. I would move to
Thank
adopt
you. That's
that.
Sharon.
Yes. Mm-hmm.
And this is
Anybody
Kevin.
else?
I would second that.
Thank you so much. So that's all we have on that item. But before we go off, I'm going to hand over to the chairman, the conference chairman, to conclude. But let me have the opportunity to thank him and all members of the organizing committee. There's quite a number of us in that committee. And I don't have the time to mention everybody by name, but I'm sure you might have seen that slide, might have seen some of the names as they rose up in the credits. The chairman himself, Dr. Simutoe, the secretary, Cassandra, Dr. Laurie, Dr. Burns, Dr. Sibuzo, Kelly Simmons, Kevin, Sarah, Sharon, and so many others. So we thank you all for putting this meeting together and making it to be possible. So at this point, I think we'll first move for adjournment, and then we'll call in the conference chairman to close the meeting for this year. So who is moving for adjournment? I see Ngui's hand up. Kasangi. Kasangi, do you want to move for adjournment? Or Kasanji? There.
No, thank you very much, Dr. Osoro and colleagues. It was a very good experience. I think I will post whatever my experience and my concerns into the platform. I'm from Lesotho, and so far we are struggling to have the same experience like colleagues around the world, to have a Lesotho blood medicine and surgery, bloodless medicine and surgery program. So far we are depending on such a platform like this one and the conference, which we are benefiting from the experience of colleagues. So we thank you very much. I'm quite sure that in a very near future, we'll also be able to have our own program locally. We thank you very much for everything. We would like just to ask, I have seen a couple of presentations on YouTube. I don't know whether all the presentation for the past 3 days are posted in the group. Thank you.
Nat, are you still there?
Hello. Yeah. Okay.
Ananthi, did you have a comment?
I'm so sorry, I was thrown out by the network.
Okay.
So did someone, I heard parts of the comments from Lesotho, and I'm very grateful for that. And I think we wanted someone to move for adjournment.
I'll move for adjournment.
Thank you very much, Kevin. Who is seconding?
I second it.
Thank you, Ananthi. And therefore, this meeting is hereby adjourned. And let me mention that I forgot to say that for now, we intend to maintain the virtual format for this meeting in view of the challenges of international travel at this time. So we look forward to seeing you again next year, about this time, November 1st to 3rd. And with that, I hand over to the conference chairman, Mr. Christopher Simutoe.
Thank you very much, Dr. Osoro. I would like to thank all the speakers at this conference, all the moderators and panelists, and all those who have been with us virtually around the world. The organizing team working in the background to make things happen. This has really been bloodless medicine education, the ultimate game changer. Let us all find ways of improving the care of our patients using the methods and techniques discussed. For those in supporting roles like the LHC members, they utilize the information by informing doctors about what you have learned, refer them to the Bloodless Medicine Surgical Society for more information. Let us continue learning and putting in practice evidence-based practice. Special thanks to the president, Dr. Nathaniel Osoro, for bringing out such a powerful team. I can tell you the last time when Osoro told me that I might chair this one, I said, oh, wow. And the really amazing things have happened to me because in my practice, both myself and my wife are retired, we have a private practice. And on Tuesday, when the official opened, our clinic was approved by the Medical Council. So we started meeting patients, we started operating as well. So by 15th November, we are starting a fully fledged bloodless program, possibly to be the only practice at present in Zambia providing bloodless program. And I'm sure in the coming years, I'll be updating the BMS committee during the meetings. Please, it was a wonderful meeting. Let's enjoy ourselves until we meet next time. Thank you very much. Bye.
Thank you. Bye-bye. Bye-bye, everyone.
Thank you, everyone.
Thank you.